Hello, hello. No. I did glasses. What? You putting glasses is really hard. My glasses? No, it's not hard. It might be mine. Is that right there? Is it no presentation? Yes, I think Tiana is she's really good. Oh, you are not. I did forget about that. Isn't it right there? He's on. Thank you. Oh my God. There's a whole okay, so just look it up for me. I can help you.
Which presentation is yours?
Oh, yes, this one.
This one?
Okay, yeah. You can start with supplements. Good morning, everyone. How's everyone feeling today? Are you ready for day 2? Yeah. Nice. So, welcome everyone to day 2 of the Gastroenterology Endoscopy, Probiotics Healthcare, Nursing, and Pharmacy conferences. Thank you for your active participation yesterday. If I didn't get to meet you guys, please let's connect after. And today we have another strong lineup of speakers and presenters today. And I look forward to a productive and insightful day with all of you. For those of you that didn't get to know me, just a little bit about me. Yesterday, I presented about the gut-brain connection. My name is Tiana once again. I'm a functional medicine practitioner and a registered dietitian, and I work from a holistic, integrative, optimizing your gut health. And I believe that we're connected to everything that makes our gut health better. So by being connected to nature, being connected to each other, being connected to spirituality, to faith, is truly what brings a lot of that emotional well-being and gut health. So we can start. Let's begin our sessions. Our first keynote speaker on day 2 is Dr. Mohammed Amabarek from Saudi Arabia. And his presentation title is Employee Engagement and Well-being or Readiness for Change. Please welcome Dr. Amabarek.
Very much. Good morning, everybody. Now, I asked you yesterday, either employee engagement or business for change, and most of you choose employee engagement and well-being. Isn't it?
Yes.
Yes, okay. Because it is only a coincidence that also Dr. Zena will speak about almost our subjects are related to each other, and maybe I have some introduction, and maybe Dr. Zena will hit the real problem. Not readiness for change, employee, excuse me, not readiness for change. Who is the responsible? It is employee engagement.
That's the one they had up here, sir. Is that the one, sir?
Yes. No, no, this is their subject.
Correct. That's the one that. Maybe this one? Another. No.
This was
That's the only one I have.
have you forwarded, doctor? The
Yes,
other one
yes.
was-
Did you turn it?
Yeah.
This is not yours.
This is another one. We ask the people yesterday which one they choose employee well-being. Maybe Miss Bianca, you know that.
We chose the second one, right? Right, we chose the one for today.
Yeah.
Where I'm asking the other one. I got only two photos for this one.
Should I send it again or what?
I asked them.
Huh?
I asked them to send.
Yeah. Then we find solution. We cannot ask people to care for others if we don't care for them. The system and leadership don't care for them. I want you to care for the patient. I have also to care for you as an organization. If we fix the people, we cannot fix the people. If we fix the people, we will fail. But if we fix the system, the leadership behavior, people will thrive. Till now, I think there is a gap between leadership and the people. We need more education for the leadership actually, to be more engaged with the employee in every organization, not only in healthcare. But in healthcare, it's particularly sensitive because healthcare force will deal with the fragile people. A patient is a fragile case. That's why we have to take care for our people, that they care for those fragile. Yeah, okay, found it?
Yes.
We will touch all this. The most important is leadership strategy to effectively engage employee. As I told you before, Dr. Zena, I think she will explain more about this aspect of psychological issue. Employee engagement is emotional commitment to employee toward their organization. It's emotional engagement. Why employee engagement matters for patients? You see, engaged employees, they have more compassion for the patient, higher engagement, better communication. Actually, the second patient safety goals is effective communication. Communication is a problem in the whole world, actually. If you remember the catastrophic event of Columbia Space Shuttle and Apollo, the root cause was a communication problem between the engineer and the higher authority. The engineer could not express their concern to the higher authority for different reasons. We just don't know to dig in that matter for different. That's why communication is a very important subject in our life, even between us and our children. We have a lot of miscommunication sometimes. Employee engagement. First of all, communicating effectively. How to communicate effectively? You have opportunity to communicate leadership round because you are talking about leadership. This is here our core issue. Leadership rounding. You know, many of the leadership, they are sitting in their highly furnished offices, closed, nobody come in, only very rarely, and they don't go out, they don't go to the field, they don't see what the people are suffering or what their employees. Leadership rounding is very important. Hourly rounding, leadership, that does not mean only CEO. The leadership, the whole hospital, there are a lot of leadership figures. Daily huddles, opportunity to listen effectively, not only listen and you are looking there. You have to listen to the people, either employee or not employee. How can we know about listening, not only listening when he talks, also we have pulse survey, storytelling. Let them tell their story. Let me tell my story to you. This will relieve me. I will have more connection with you. Surrounding town halls. Yeah. Do you know what is pulse survey? Oh, pulse survey. You know, we do a lot of surveys, particularly either twice a year or at the end of the year. But pulse survey it's a continuous survey, maybe every month, every week, we do a small survey to check how is the situation. And we have in short time feedback from the people. Through employee engagement, we have patient satisfaction, higher, fewer employee safety incidents because they will talk about their incidents, we correct them, we help them how to correct it. Less patient safety incident, less quality issues. We have several leadership strategies to effectively engage employee. Know and communicate the organization leader must walk the talk. Not only talking, but you are not doing that. It's only for talking. I was three months ago, I was talking to one physician. The physician of my children since 25 years. And he told me, what you are doing, Mohammed? I said, I'm preparing for a presentation for quality. He said, oh, come on. He has a long experience in a very huge private hospital. He said, come on, Mohammed. We hear that only in presentation, but not in the actual way. This was 3 months ago. That means till now, we have a problem with the real walking the talk. Provide employee with a voice, two-way communication, not only one-way communication. I am the one here who decides, who tells, who knows everything. Create open door policy. Speak up, let the people talk. Let them to vent what they have. You have more connection. Create an intentional culture. You want this healthy culture. Accountability drives structure, and structure drives culture. This is Fred Lee. This Fred Lee is a management professor. He is known for if Disney ran your hospital. He's yani, we have to learn from Disney how to run a hospital. That we make people happy. They don't feel when they come to us. Let them come to feel enjoyment when they talk to us, when they are with us in the hospital. It is a very nice book, actually. He believes that it is not possible to create a world-class service culture if structure defined by layers of bureaucracy and departmental barriers exist. Lead. Silos, everybody, every department alone, no connection. No, this is not my problem. This is a nursing issue. If somebody has a problem, ask him, go to the mudir, go to the manager. No. Sometimes you have to solve the problem if your leadership remove the barriers between you and them. Please remember what Fred Lee said, because we'll come to that later. Support for professional and personal development. Offer access to online courses, certification, set up a mentorship program, provide regular feedback, performance review, encourage goal setting and personal achievement, and give the people something that they give you back something. What does Fred Lee suggest is critical for building a world-class service culture? A, increase hierarchy and bureaucracy. B, avoiding structure altogether. C, accountability and structure alignment. D, prioritizing only cost saving.
C, accountability or structure alignment.
C. Somebody has another? C, you agree? Yes. Accountability and structure alignment. That's why we said, if you have accountability, then you will be having roles, regulations, and everybody knows what he is responsible for. And this is now the structure. And this structure will build the culture, how we talk to each other, how we communicate with each other, how we work together. Foster employee well-being. Create opportunities for staff to reflect together and talk about work, implementing strategies of Schwartz rounds, We know Schwarz round. We don't have it in our hospital till now. I tried to implement when I was CEO of the hospital. Second victim group. During my presence as CEO, it worked a little bit, but when I left, nobody was caring for that. I'm sorry to tell that. This is the truth. And Schwarzschild is something like second victim uh, group when we have a sentinel event. But Schwarzschild is actually let people give them time to come together. We talk about our problem, what we feel, what we face today. Give them every time, every day you give them, every group have time to talk to each other. This will encourage them, vent what they have, to tell you if there is a problem, to tell you maybe how to solve it. Engage in social interaction outside. Maybe you will say this is only, as the doctor of my kids said, it is only in presentation. But there are some hospitals in the States and somewhere else, they are really starting doing this by book. Organize team outing or dinner, celebrate birthdays, milestone, volunteer as a team, host a family-friendly gathering. All these things, يعني, the connection with the people, not only with the employee with the patient, the employee with the family, all together, let them feel, they don't feel a stress or distress. Let them feel maybe we want to make the hospital like a home. It is not, but we try to approach that level. Question: how can leadership support professional growth among staff? A, by avoiding discussion of future roles through mentorship, coaching, personalized career, by discouraging training only through standardized annual review. Exactly. Through mentorship. Mentorship does not mean that it's training. It is something different, actually. They feel that you are with them. You are telling, you are showing them what to do. They are asking you what we have to do. They don't shy. Please tell me. And they feel that really caring for them. You see, caring is the most important thing. 7, demonstrate appreciation for contribution, big and small. Recognition is a powerful approach. Celebrate wins publicly, personal thank. See, go and say thank you. You know, sometimes the people think, oh, they don't need your money. They want to say, you feel with that you recognize their effort. Say thank you. That's all. Yeah. We have one time Minister of Health. He said, please only smile. It was a slogan. And everybody was laughing, but this is true. He said, only smile. So smile to the people. This will break the barrier. If you smile to, not the patient, to everybody. If you smile to Dr. Azair now, it will break the barrier. Have eye contact. Very important. You have the eye contact when you're talking to the people or listening to the people. Eye contact, body language, more than 50%. The people understand the body language than what you are talking or writing. And then we come to coaching. It's what what we said before. We don't need to. A patient experience, PX means patient experience. That's why I wrote CPXP, patient certified patient experience professional. Again, CPXP is one of the really very important certification. Do you know when I got it? You don't know. I got it 4 months, 3 months ago. I'm still learning. I went to the exam. I sat there for 3 hours. I answered the questions. Keep your mind busy also with something useful. Okay. Coaching, patient experience coach wants to help staff to reduce patient complaints about noise at night. What coaching method is most effectively? Assign blame to night shift staff, facilitate team discussion to identify small testable changes, inform staff to, or change the schedule without staff input. B, sit and discuss. Discuss the problem. I remember when I did my exam for OBYGN in Austria. The exam system in the German system is oral exam. There is no written exam for medical school. If you are ready for that stuff for this for surgery for OB, you have to come and sit in front of a whole people. This is the big hall. Also, student can listen to you, and you have a conversation with the professor oral. He will ask you 3 or 4 questions, and he will decide if you fail or not. It is for us. We are not used to that. We have to write in our area. I came to the OBGYN. This professor has like a pot there. He said, draw 3 questions. He has like draw 3 questions and start. I draw 3 questions, about 150 students sitting there. I opened the first one. Oh my God. I told him, Wallahi, professor, I am sorry. I want to go, khalas. I don't. He said to the student, look, he is thinking about to have coffee. He is meaning me. But you have to know, Mr. Muhammad, that there is only one person here who can decide who go and who sit or comes. You have to start answering my question. I started answering the question, the 3 questions, and he said, okay, you succeeded. Why this fear? Actually, we have to break the barrier. If you are in fear, it is disastrous, actually. And most of the employee, really, they fear the leadership. Tools for employee engagement, as we said, leadership rounding, role modeling. They have to be walking the talk, not only talking, like partnering with the patient, experience leader, coaching, workshop, education, and training. Those are the tools where this is our conclusion, the conclusion of the. What I want to say, the conclusion, employee engagement, employee well-being. It is not a leadership choice. It is a requirement. This is the message. It is a requirement, not a leadership choice. I wish you all the best. Thank you.
Thank you so much for that insight, Doctor. I have to say, someone that worked in the hospital for 9 years, when my manager started holding people accountable and really forming, creating these group sessions, and where everybody was able to, speak what they're going through or feeling and really getting engagement because we all matter, right? It doesn't matter what position of authority you're in, right? It's how do we come in and we make the change. And it was interesting because she made a comment saying that when we hold people accountable, it's actually a form of love, holding people accountable, right? And,
Yeah.
and I believe that connection is everything, right? Not just the body, but when we're connected with each other, patient satisfaction will go up because I actually got to see that with my own eyes. So seeing you talk about that was very insightful. So thank you.
Thank
Does
you.
anybody have questions? Well,
Thank you very much. You see.
yeah, Bob, if you can come on the stage and throw the certificate and a photo together, please.
Thank you. Thank you.
All right. And our next keynote speaker is Dr. Zaina Gusau. She's a coach in leadership and wellness. And her presentation title for today is A New Model to Combat Burnout in Healthcare Industry Using Coaching, Wellness, and Emotional Intelligence. Please welcome Dr. Gusau.
Can you see me? All right. So Dr. Muhammad, thank you for alluding to what I'm going to talk about because this is a very dear topic to my heart. And as Randa talked yesterday and Luciana and many of you, this comes from a very personal experience where I have a husband that is a physician also, and he is an emergency room physician and an internist in the United States. So what prompted when I became a coach like 20 years ago, I'm one of the earliest coaches in the world, I gave him an emotional intelligence test to take. He didn't do it because he was screaming at our 2-year-old as if he understood what he was taught. Second year, third year. And then he took the test. And his flexibility was close to 0. And then I used to hang out with a lot of physicians and doctors and all of that. And what really happened is I saw that these people are totally burned out. And emotional intelligence will support them. And this is how my journey started with working in healthcare. Because I come from a background of wellness. I'm a dietitian, a bioscience technologist, and then I became a human behaviorist and counseling. So along the path, I gathered all the mind and the heart and gut work to help basically a human being become well and a leader of themselves. So this is where this starts. Now, in 2013, we created Vital Science, Vital Skills in the States as a coaching, consulting, training organization for physicians, nurses, healthcare administrators, and we started doing research. And after that, a book was published about burnout in physician. And as Dr. Muhammad said, well-being is not a need, it is a necessity. And I've been working in corporate wellness for years now. And in the healthcare industry, it is even more needed. This is not working. Is it working? So usually when I start my presentation, I ask of most of you are physicians here, aren't you? Yeah. Yeah, okay, but most of the physicians I work with, I ask them if they're burnt out, or most of the nurses I ask if they're burnt out, they say maybe one hand goes up in the room, maybe two. When I finish usually my presentation, I have all hands up. And so burnout it's a disease. So today I'm going to talk a bit as brief as I can because I have a lot of information for you about burnout in the healthcare as a pandemic, why it matters, understanding what really burnout is, and the CAP and the current approaches, and what are some interventions. So, burnout is defined by the CDC as it is a workplace disease. It's a disease. We need to understand that it is a disease. It is very symptomatic of post-traumatic stress disorder. So it is not only stress. It is not, oh, I'm burned out. So it is workplace disease. And nearly half of healthcare workers report burnout. Can you imagine? Can you imagine that half of them are reporting burnout? What does this mean? This means they are working out of 50% capacity of what they can work of. They are not able to, the research shows how many mistakes they do dealing with patient care. The research is, thank you. Also looks at how they don't want to come to work. And the stats talk about a rate of the death of 400 physicians a year because of suicide. Imagine that, more than one physician a year. And post-pandemic, it became worse. And I think Tiana knows that how much there was an exodus of nurses and physicians. They don't want to be physicians or nurses anymore in life. And it is a real problem. Some studies even show the rates as high as 75%, and you can see the literature below. So it's really it's a no-brainer why it is important that we tackle this. As I said, patient safety and clinical judgment is affected up to 70% with physicians that are burnt out. When we do the MASAC burnout assessment, because if I want to assess if you are burnt out or not, I will run on you an assessment. I am an assessment person. I do human behavior. So I want to see, I'm a scientific person. I want to see. So I will run on you an assessment and I will see. I will look at depersonalization. It means like, I am not the person anymore. I am robotic. You are a number for me. You are not a human in front of me. And this is how I'm going to be dealing with. This is one. The second thing is emotional exhaustion. And the rate in women doctors is higher than male doctors, by the way. And emotional exhaustion because women are caretakers of the household also, all over the world. So it becomes even worse. And the third thing is that they are not able to accomplish their purposes. So in the MASAC burnout testing, what I see, so I can assess if I do have somebody that is burnt out or not, from a psychometric standpoint, I will have these three that I look at. I am not still talking about physical well-being. I'm not talking about their symptoms. I'm still talking about their brain. Okay? Emotional exhaustion, and it affects the hospital's money. a lot. There is no retention, financial stability, because these physicians, when they're burnt out, what do? They take sick leaves. These nurses, they take sick leaves. They are always on medications. They are always they are oversleeping. Now, I'm not going to talk about the depression. I'm not going to talk about the use of drugs, alcohol, and all of that, because there's a lot of that happening. And if you look at the literature, you will be mind-boggling. So, what are some factors, and preluding to what Dr. Muhammad said, what are some antecedent factors? First of all, high patient load and staff shortages. Really, in any hospital, you all work in hospitals. How much do you hear that? Like, they're always short on staff. They are always recruiting, and there's a high patient load. So there are not enough people. And nowadays, with the Gen Zers, which I mean the people that are born after the year 2000, they are having even more shortages, because if we look at the personalities of the Gen Zers, they do not agree to overwork themselves. So there will be conflict with the millennials and the Gen Xers, which is another topic altogether, because when I do team coaching, that's another thing to teach. And this is what also Dr. Muhammad talked about here, is that they all need to sit down and talk to each other, but they don't, they fight. Because they have different expression in communication, they have different expressions in emotions and communicating styles. So that is another factor to look at. Emotional labor. What is emotional labor? Emotional labor is that I am seeing sick people all day long, and I am exhausted emotionally, because I am not a robot. I am a human being, and I'm taking that parent that is living with a sick child all the time. I am dealing with a lot of emotions in the day. Physicians are exhausted. The highest rate of suicide in physicians is in ER physicians and surgeons and people in urgent care and trauma specialists. Yeah. Yeah. But every physician is burned out for me, except the one that has and the nurses. Okay, I'm not going to talk about the nurses, and I'm not going to talk about the healthcare administrators. The administrators even have a bigger issue, because if they are like Dr. Muhammad and they do care about the people, they bring their problems home. Okay. So long shifts, administrative burden, and now physicians all over the world, they are not only best physicians, so they need to do administrative work, they need to write down in their charts, they need to log on to their EMRs, they have a ton of things to do, and they are always not following up. And limited autonomy. Limited autonomy is that people control their schedule. You have no freedom. As physicians, as nurses, you have no freedom. I had a nurse that's a Gen Z, I'm working with now, and she says, I cannot do any more night shifts. I do not want to be a nurse anymore. So that is all are part of the antecedent factors that are recognized by the literature. The gap. Okay, in Arabic we say بالمصدر. Yeah, we need to do well-being, we need to self-care, we need to balance without we need to do all of this. Yeah, really? Okay. Hey, how are we going to do that? As an individual, can anyone do anything alone? It's a system. The system needs to change, the whole system. So Dr. Muhammad, you are a visionary, especially in the Middle East. And I'm so proud that I got to meet you because I do this work in Saudi Arabia also. Or they're calling out to me every day this couple of years because I'm back in the area. And this is not what many people talk. So I salute. In the Western world, they do the same. They talk about helping people, but what are they actually doing? Not really much. So the way to do it is by practicality, by understanding the problem, we go in as well-being experts, we do assessments, and then we decide, okay, so this hospital needs A, B, C, D as micro initiatives, so we can get them started, and we create wellness champions, and we create committees, and we follow on these things. This is why well-being coaches, health coaches, wellness coaches are in so much high demand now. And now I need to explain to you in a bit really what coaching is, because there's a big misunderstanding on what really coaching is. So we help that individual build that emotional capacity. We reconnect with their purpose. How many of you went into medicine because we wanted to save people? How many of those physicians after a few years will, I really don't care about these people anymore. I'm too tired to get another patient today. This is very normal. So they cannot connect with their purpose anymore. So what we call in coaching intrinsic motivation is lost totally. So connecting to their purpose, strengthening the resilience. How do we do that? Strengthening the resilience and grit takes time and effort, and it's everything all of you were talking about yesterday, from the body to the mind on a daily basis, from mindfulness to meditation to exercise to the gut to everything that will help us from the body perspective and also the mind perspective and the willingness to actually work. But it takes time. And where are we in this life, in time? We want things to happen when? Yesterday. Not today, yesterday.
Even last week.
Even last week. And how are we going to help them develop their inner resources? What are their own strengths? Does Randa operate like Luciana, like Dr. Hamad? No. Every one of us operates in a different way. So we have to tackle these strengths that are very important in them and know their not weaknesses, but what are the things that they need to upgrade in them. That's why I created this with my physician husband to help them. And this model is coaching, emotional intelligence, work-life integration, and reflective practice. And I'm going to go through all of them. This is our book, published like 7 years ago. And now we have another book, it's called Coaching in Healthcare, that has been published last year, December, that talks about how the importance of really coaching in healthcare. So there are several intervention points that coaching can help with, regardless of the approaches. But before I do that, so what is coaching for you? Hanan, does anyone can define coaching? Know what coaching is? Yes?
I would say motivation, empowering patients.
No.
Changing behavior, perspectives, modifying something.
Yes, it is definitely change. It's sometimes some coaches call themselves change facilitators too. So it's changing, but how? The how is very important.
Guided as per the individual person's whatever they want to achieve.
Yes, we follow what they want to achieve, but do we tell them what to do?
So,
No.
We invite them.
No, we tell them they have to come up with this. Not
Yes,
we can guide
yes,
them.
yes, exactly, yes, so that is a very important distinction, because coaching is totally different than mentoring, is totally different than counseling, literature has shown that if a human being has the ability to come up with their own solutions, then these solutions are going to stick. They're not gonna go away. This is why coaching works. It actually rewires our brains. If we look from a neuroscience perspective, there's a lot of literature that shows that coaching will help you in rerouting some wiring in the brain and shifting category. This is why it works. And this is why it is very, very, very powerful. And this is why I stopped being a dietitian and I went into human behavior and became a coach, because I used to give those patients of mine the diabetic diet and they didn't do it. And I used to give them a diet for hypertension and they did it for a couple of months, but there was a whole lot of failure. Because if you don't change the behavior modification is the most important thing. And this is why understanding these physicians, understanding their environments, their new demands, and more importantly, coming to accept them where they are is very important. Developing the ability and the skill set to thrive in a new healthcare industry where the demands are a lot, where leadership is a must. It's not only about just helping a patient, it's about so many other demands. And turning the me versus them into the me and them versus the problem, i.e. working together. This is very important. So coaching will help. This is one methodology, and it will help set realistic expectations. It will develop a healthy sense of control, that I am in control of my life. Again, it will reassess your goal and purpose. Why am I a gastroenterologist? Why am I a neurosurgeon? What am I here for? Adopting new behaviors and understanding why behind them. Others, including but not limited to some family struggles, a lot of struggles. The highest rate of divorce is in surgeons, by the way, in the world. Because they don't come home and they don't know how to communicate. Professional challenges, barriers, institutional constraints, these are to name a few. So any obstacle that is perceived to exist by the doctor could be a focus point of coaching. And what do we do as coaches? We just sit. We sit and we see, hey, what do you bring to the table today? How can I be of support to you? With no judgment. This is their space. This is their time. And we are working with your agenda. And once you do this time, over time, things will start shifting at an individual level, and then they will start shifting at the system. So I've talked a lot about coaching, and of course, your self-confidence increases, your self-efficacy increases, long-term health behavior increases. How many of you have challenges exercising? The first thing I hear is like, I don't have time. I cannot eat properly. The amount of physicians that have urinary tract infection is mind-boggling. They don't drink water. So coaching works across different platforms, and this nowadays it's really easier. We do it on the phone, we do it virtually over Zoom, we do it in person. We do it as a team, and in teams it's very, very effective. And there is a difference between group coaching and team coaching, by the way. So team coaching, we work as a team. Group coaching, we work with one agenda. So all of these help. I want you to look at this study because this is a very beautiful study that comes from 2022. So in April 2022, the researchers recorded the brain activity in the region associated with problem solving. And three approaches here were compared. The first approach was just to sit down with yourself and personally reflect. The second one is when they received advice from a mentor, from somebody, and they gave them their opinion. And the third was only non-directive coaching, giving the space with no judgment and open-ended questions. Open-ended questions means what, where, when, how. We don't close the question. There's I train coaches for a living also, where our program takes a year to graduate. So it's really a very in-depth program. The greatest brain activation in the creativity region occurred using non-directive coaching. Look at the activity of the brain. Look at the activity of the brain in the first segment here, and look at the second. But look at the brain activity. Why? Why is this happening? Because the brain is trying to literally find solutions on their own and rewire. So this is just fascinating for us to see people in the coaching industry. Now, emotional intelligence. So everyone says emotional intelligence, emotional intelligence, emotional intelligence. So the raised power is emotional intelligence. You have to be really certified in doing an assessment in emotional intelligence to know how to debrief it. Not go online and do an assessment online, that's it. Because if you don't know how to debrief an assessment, we cannot do anything. So emotional intelligence, we are looking at our self-confidence, we are looking at our emotional awareness, we are looking about how do we control our impulses, we are looking about how do we take our decisions emotionally, how do we manage stress, how are we empathetic, how do we deal with our community, what is our social responsibility. You get a score. And people don't like these scores. But if you accept them, we start working on them, and guess what? Your emotional intelligence never stops growing. It peaks at the age of 48. Why? Because of life experiences. However, it will dip if you don't self-develop and learn, as Dr. Muhammad is saying. So it is very important to understand where we are in the moment, like a blood test, and so we can move forward. And this is what we do in our model with the physicians. We run on them we run on them an emotional intelligence test, and we see where they are, and we start working on their area of what they need to reconnect with their purpose. And this is why they get better. And the research is like sometimes within 3 months we remove their burnout, like completely, which is very interesting. I'm out of time. So okay, so the third part is wellness and work-life integration. I do not like the word work-life balance because it doesn't exist. There's no work-life balance. Work-life integration means you do what works for you and what you can integrate in your life. And wellness is everything that we have talked about yesterday. And the beautiful colleagues talked about yesterday. Your gut your sleep, your mind, your heart, meditation, your spiritual life, your social life, your financial status. It's the whole wheel of life. This is wellness. Wellness is not only going to the gym and what we eat and how our system is working. And we look at these, we look at their rest rituals. How do they rest? Especially the people that have those crazy shifts of nights and days and nights and days in the healthcare industry. We see what are they aligned with their values in life. Are they aligned with what they're doing or not? Because we also in coaching go through that. And we try our best to focus on their strengths in their work. Because the literature also shows that if you work on your strengths, you will augment the parts in your life that are weak, even if you don't work on the weak ones. So this is a strength-based approach. So we see emotional stability immediately, we see better communication, higher resilience, and a reduced turnover and intention. So the pillars of well-being is self-mastery, as I said, and emotional intelligence, supportive coaching, wellness, and integration. Burnout is preventable. So we do not want to reach a stage to become burnout. We have to create well-being programs so we will not reach that. Nowadays, it's not only the healthcare, I'm talking only healthcare, but I do well-being programs everywhere because everyone is burnt out. Every industry, every Fortune 500 company that I'm working with is burnt out, these large organizations. So thriving is teachable and coaching offered this pathway. So we do, one of the things that we created, and it is really very powerful, is we graduate coaches since 6 years that are physician coaches, nurses coaches, healthcare administrator coaches. Why? We are helping them help themselves so they can help their teams. So we offer definitely ICF level accredited programs on that. And I also teach programs for coaches specifically to know how to deal with burnout, because that is another thing, is helping the coaches know how to deal with burnout, because not all coaches know how to deal with it. It's a very specific niche. And that's about it. Thank you.
The tears were coming down when we were talking, because when you started talking about burnout, it just brought me back to when I was working during COVID season and how to see everyone losing their passion to healing. And when you said we started losing the nurses and we started getting traveling nurses, and it just became like money. You heard for the money. And when I saw that, I literally got that intuition that said it was my time to leave the hospital to become the advocate for, the message, right? Bringing the message to the world that emotional intelligence does matter, right? We all are here to grow. We all have our blind spots, right? So when we're helping being the advocate, being the example for as a coach, right? Judgment doesn't exist, because judgment actually, I have learned from emotional intelligence. I just took a course in the last 2 years. So I can actually teach my clients that anytime we have this energy conduit, like, if we feel judgment or there's anger or resistance or fear, but what judgment is interesting is because it is a reflection of you.
Yeah,
right? It's an internal
channel it.
conflict.
Yeah.
Right? We're mirrors for each other, right? So we're here to show you your potential, right? We're here, love is truth in action, right? So accountability. And this is the future. And just hearing your talk, my tears were coming down the whole time. So
And thank you for saying that. And because I do work across cultures, the American, the Western culture is totally different than the Middle Eastern culture. Also, we have to take that into accountability, because showing of emotions in the Middle Eastern culture sometimes is not something that is taken well. And this is why I thought Dr. Muhammad is a visionary, because it's a weakness to even to do that. And and talking in front of each other, we say, listen, I'm really not doing okay. That doesn't fly well. So it's very important also to acknowledge that. So thank you. Yes, do you have questions? Yes.
Thank you so
Thank you
much
for your
for
very important lecture. Go.
That's why I tried to be today's
And he wants to join us in the conversation. That's fine.
Thank you so much for your presentation. Actually, once you are high risk, so why there is no training from the beginning for the faculty or healthcare team who will join at the first time, where there is no training session for them before they will expose to the burnout. So if we have training for the people who will join at the beginning, will prevent the problem from the beginning.
That's one of the things that I started actually in Lebanon and in Houston. At the university, Lebanese American University, I created a program called Behavioral Sciences where we teach Med 1 students to Med 4 students in emotional intelligence, strength-based approaches, coaching, and all of that. So, and the literature does show, and also the University of Houston, the thing is money. People don't want to invest in this because for them it is extra money. And even even if you think of coaching per se or self-development or emotional intelligence, you can start teaching it from when they are actually 3 or 4. And I have several curricula in that for schools. I created the coaching chapter in Lebanon, and I'm part of the board of Houston. So the thing is, the value is not yet understood, but people are getting to it, and the Gen Zers and the millennials are forcing us, which is a beautiful thing because they are fed up. They're fed up of overworking because the culture of overworking doesn't mean that you are actually doing anything. Doesn't mean if you are busy, that is good. Productive busy is good. So I totally agree. It has to start very early on before they practice medicine. Yes.
Thank you for important lecture. Actually, you have so important role as a coach in this system. But what about physicians? What about me? What is our responsibility in this system?
To become a coach, I just told you.
No, to become a coach. As a physician,
Yeah.
in the relationship with other colleagues.
Yes.
Yeah.
That's emotional intelligence. When you are working with other colleagues and when you breed a culture that is very highly emotionally intelligent as a team, the communication shifts. This is what Dr. Muhammad also talked about. The lack of the judgment decreases. There's more open space. There's more expression. There's more vulnerability. So teaching, we actually do trainings in emotional intelligence to help the whole system increase so it becomes better. This is how it works.
And other question, what's your idea about difference between burnout and workaholic? Because very of us are workaholic actually.
Yes, that's true. That is so true. So that from a coaching perspective, we look at it when we do a coaching session and we go with your value system. We look at where are your values and why are you working so much and why are you a workaholic? Where does it come from originally? And what brought you to the place? There is something in the wheel of life that is not balanced. Since the wheel of life is an 8 arm, the wheel of life, which I mean your social life, your financial life, your relationships, your family, your friends, your leisure time, and all of that. So there is an imbalance in the wheel of life. In burnout, it's totally different. In burnout, it's more about you really become depersonalized, become sarcastic, and you really don't care. You're emotionally exhausted, like completely. And your only purpose is there is no more personal achievement. Like, really, I don't want to do anything. And there are psychometric assessment tools for that. The Maslow burnout and the wheel of life and other tools.
Thank you.
Yes.
Thank you very much. Thank you for the really, I'm very interested for emotional intelligence and I want to tell our colleague there, take care of your dopamine producing nucleus in the midbrain, and then you will learn how to control how you improve your emotional intelligence. As our colleague said, she said, before we start working, we should introduce the people to those terms. But I think, Dr. Zeno, what we should include it in the curriculum of the nursing and medical. Yes, it's very, very.
This is what we are doing, actually. We started to do that in several schools. I'm not talking only about me. But there is a lot of resistance. But now the literature is saying it's not something that's a luxury, but it's a need. If you look at the literature of medical students and how addicted they are to alcohol, marijuana, cigarette smoking, vaping, they can cope with only their studies because the system is very rigorous. It's more than 60%. I'm not talking only in the Middle East, I'm talking across the world world. So yes, it's something that's fantastic nowadays, and especially with what technology is doing to our brains. When we look at the brain of a Gen Alpha now, and Gen Z and millennial, it's totally different. So, and we are trying to tackle issues like, I don't know if you've heard this new book, I really love it, for people of the parents, and it's called The Anxiety Generation. It's in my book club now. And what's really nice about it is it talks about how our brains are changing across these generations because of what technology is doing to our brains. So yes, it is mandated.
And also we have to change our behavior actually, because can I tell you only one story? Yes. When one of my daughters, when she was about 8 years old, her name is Nora. We were playing, I was that time playing with her and said, okay, we have a card. And I told her, okay. He said, yeah, you decide, Papa, how we start. He said, I told her, yes, I am the mudir, I am the manager, I am the director. He said, Papa, you are not director, you are leader. You lead me, not you are director. That means do that and lead that and do. Leader is showing you how to do it. And that's what we are lacking at. Thank you.
Thank you. Oh, we still have a question. Do we have time?
Yeah, I'm gonna go find the talk. This is really important information. Thank you, Doc. Interesting you said about the leaders. We're all leaders when you think about it. Every connection, right? Not just with work, with each other. Only I want to say that coaching is priceless. It was my experience as a dentist and as a celiac survivor. Coaching is priceless. Like if you go to the gym, you have all the machine, yeah? You can train by yourself. But if you have the personal trainer that know your body, your target, you will be there more fast and more safety. So for me, coaching is really priceless because we need to be heard, all of us. We need somebody to hear us.
Yes.
And this is really what we need. Thank you.
to concur on what you're saying, now, if we look at longevity and the research on longevity, you will see that people that are in a community and they connect, they live more. Why? Because they are heard by their friends and family. So now they are creating this awareness. Like we've been talking about this for ages. That is one aspect of coaching. But yes, I am, you're preaching to the crowd. So I am basically, I've been a coach for 20 years. And when I told them I want to become a coach, they said, what are you gonna actually train a soccer team? Like, what are you going to do? Like, so, yeah.
Yes, hi, Dr. Zainab.
Yeah.
Thank you so much for the beautiful presentation.
You're welcome.
I have a question about the data that you have shown before. Do you know, as you know, the literature in this area, do you know what is if there's any specific like data in
The Middle East?
no, in this, like in healthcare coaching, because what you have shown, I think is general, it's not the population targeted in this study. It was not for like in.
No, it is for healthcare.
It's in healthcare.
Yeah.
And do you know, as we know in North America, for example, the prevalence of suicide, even in universities of medicine, are very high. So do you know if there's any implementation of this coaching, like in universities in US or in
Yes.
Canada, for example, or is there any like they concrete is concrétisé? Sorry.
Tu peux parler en français, je comprends.
But for this, c'est comme est-ce qu'ils ont concrétisé pour ça? I'm sorry because I'm mainly French speaking. So.
Yeah. Yes, the answer is yes. They
Okay.
are starting it in universities and in the Western world, specifically North America and Canada and Australia, where they are putting it in the curriculums. Yes.
Oh, okay, okay. My last question, you talk about la différence culturelle comme
Oui.
North America versus comme l'expression des émotions et tout ça.
Oui.
Have in your program, for example, have you this to get up, like adapted to
Yes.
GCC, for example, if you want to implement this or
Yes.
have agency here,
Yes.
have you adapt this to the cultural context in our area, like in the Middle East or in?
Yes, this is why I'm called for. So I was born in Africa, raised in America, raised in Lebanon, lived in Europe, and then went to the States.
Wow.
So one of the things that is very unique about me and why I know how to deal with different cultures, because it is very culture sensitive, very. Because when I'm dealing with a Nigerian, which I have been last week, for example, it's totally then when I'm dealing with some person from North America, or if I'm dealing with a European. So yes, it is adapted, cultural sensitive, and the coaches I'm training and the people that work with me, they are all trained in that.
Thank you so much.
You are more welcome.
Thank you.
All right, thank you all.
I'll actually leave you guys with this, that I just learned from my emotional intelligence classes. This is powerful not to share. So I learned that every emotion it's not a such thing as good or bad. So there's not a negative emotion. If there's anger that comes up for us, if there's hatred, if there's fear, any emotion, it's not a negative emotion. It's simply an invitation for us to go deep and understand where it's coming from, because once we process it, understand it, right, you gain the wisdom to release, that's when we're able to communicate better with each other. So all right. Well, next speaker is Ms. Roa Ahmad from the Eastern Health Cluster in Saudi Arabia. And her presentation title is A Comparison of Newly Qualified Nurses' Attitudes Towards Mental Health in Different Hospitals in Saudi Arabia. a cross-sectional study. Please welcome Ms. Aman.
Bye. Assalamu alaikum. Good morning, all. Thank you for this invitation for me and for UCG conference. It is informative speaker from yesterday and today. Thank you for all, and thank you because we are here today. I'm Ru'a Aman from Eastern from Irada Hospital Cluster, Eastern Health Cluster. Today, I will talk about the study that we done last year about during 3 hospital for nurses. A comparative of newly qualified nurses' attitude toward mental health in different hospitals in Saudi Arabia, a cross-sectional study. This abstract statement of a problem that increase the prevalence of mental health condition. There remains a dearth of research investigated that attitude of newly qualified nurses. And the gap, we see it during when this new nurses for job coming for us, and how we see how it is deficient also about the knowledge, and also how to be with the nurse, with the psychiatric patient especially. And all the time they want to transfer to general hospital or another hospital because they said we are scared to work with the psychiatric patient or addiction patient. For that, we're doing this study and toward the mental health in Saudi Arabia. This study aimed to address the gap by examining the attitude of these nurses in different hospitals and identify factors influencing their perspective. Material and method used for this cross-sectional study aimed to evaluate the attitude of newly qualified nurses toward the mental health in various Saudi Arabia hospitals, stratified random sample. And when we do this sample, that the limitation of this study about the number of the nurses who will be required, and data will be collected using validated and including by 3 hospitals. This study will be investigate that impact of hospital type, work environment factor, and demographic, and variable on nurses' attitude, statistical analysis, including ANOVA and regression. And ANOVA, it will be example to identify scientific association and different. The finding of this study will contribute to the better understand of nurses' perspective. The results of this study indicated that newly qualified nurses generally have a positive attitude toward mental health patient with an overall agreement of 75.6%. However, stigma is still remaining of this issue, and 68.6% of responded agreed of this seriously of mental health, but showed mixed perspective regarding mental health patient. Knowledge and training were related positively, but there is also improvement of the nurse demonstrated a strong willingness to learn. In conclusion of this study, that we will see how it is newly qualified nurses have a positive attitude toward mental health patients, but the stigma still exists, and education training significant influences perspective, emphasizing that need of comprehensive education in this field. Our introduction that led us to nurse also have important role play in providing mental health care, and particularly within hospital where they are initial contact person of this patient, they can form therapeutic relationship, offer emotional support, and provide mental as a physical care, hence significantly impacting that outcome of patient nurses. Attitude toward mentally ill patient can, however, lead to better, worse qualified of care. In mental health nursing, demonstrating that patients feel the health professional promoting through intensive interaction with the nurse. This study reaffirmed that positive attitude from the nurse establish health environment leading to recovery. This study showed that empathetic nurse-patient relationship that is strong is a foundation of effective mental health care. The impact of stigma in mental health leads to act individually arc to healthcare service. Examine determined the of stigma of nursing student. Their findings show educational shortcoming, personal belief, and lack of exposure to mental health. Patient during training can result stigmatization beliefs. And that's what we're showing in our student practice when they come from the university, and they said we will not work here. Even they sometimes scared to deal with the patient, to be practice and know more how to deal. Even we said this, it will be just when we also try to practice them, we feel that, and the students especially in these years. Statement of this problem despite that increase the prevalence of mental health condition, there remaining there research investigated that attitude newly qualified nurse toward mental health in Saudi Arabia. This study aimed to address the gap by examining the attitude of the nurse in different hospitals and identify factors influence their perspective. The aim of this study to evaluate newly qualified nurses, and the specific aim to assess attitude of newly qualified nurses toward mental health in Saudi Arabia, to compare the attitude of newly qualified nurses and across different hospitals, to identify factor association within attitude toward this mental health. Association was by attitude, and we do that one in the Eastern hospital and in the West. We have in the and North, in the Skaka and the Al-Ahsa and in the Mount that district. Literature review, advancement and policy mental health within healthcare facilitated. Recently, mental health services have a global change. Scientifically, there is a shift toward recovery-oriented system that integrate mental health with other form of the healthcare, increase appropriate of mental disorder. New methodologies like patient-driven approach that value self-recovery serve as good help in this regard. Nurse play key role caring individuals suffering from mental health issue and are normally the first contact patient with the mental health disability. Encounter as a hospital set up, they are responsible not only the care patient but also the condition, psychological evaluation, offering therapy, monitoring the individual physical health also, and providing guidance toward the sometimes complex and integrated mental health service. Research highlights that mental health nurses contribute in very real way to the creating therapeutic environment that aids recovery. And we're showing from this also this study how it is the nursing education and coverage of mental health. The training of nurse is fundamental component and equipment deemed to deal with health matters And Saudi Arabian nursing program have experienced considerable growth in corroborate various expected in clinical practice, patient care, specialized fields such as mental health nursing. However, research have pointed out gap of problem in the existing, especially with regard to teaching mental health issue. And impact of education and training nurse attitude toward the mental health approach, attitude nurse, affected by the education training and nurse practitioner who is going to training and the level of professional skills obtained during schooling and clinical practice, level specification with job hub, coincidence, the management of mental health issue during clinical practice. The review point out the need adequate economic training that help to develop these skills need to address the multi-faceted challenges posed by the mental health patient. The study design will employ cross-sectional design to evaluate the attitude of newly qualified nurses toward mental health, different hospitals in Saudi Arabia, and comparing attitude across various hospitals without the influence of time-related factor. Sampling size will be determined using by PowerSoft beside an estimated affected size 0.30, a scientific level of 0.05, and statistical power of 0.80 sample size. Approximately 29 participants will be targeted to achieve adequate power. This number is calculated to ensure confidence level of 95% with a margin of error of 5% presentation. Willingness to learn and improve by the difference between, it's not pure. And the different, we have here also the difference between a group of newly qualified nurses attitude, and we see how it is the nurses attitude toward mental health who have experience. It was less, they have more competent and also have, who is the higher scientificated and experience and have a more program in that one. It was more positive to perception of mental illness between males and also this size and female. The different between age group, newly qualified nurses attitude toward health, and we see that one in when about our sample. They are not statistical significant different of attitude toward the mental health patient between age group. And also this by the analytic of this our sampling. And discussion. This study offers understand the mindest of knowledge newly qualified nurses toward mental health patient. The results show there is generally positive attitude from responding, as most of them believe that recovery of possible among mental health patients, and the respond have some level of stigma and misconception of the indication that there are need more education and training program. Attitude toward mental health patient. The data show that considerable number newly registration nurses have a positive attitude toward mental health patient, as demonstrated by the mean agreement score of 75.6 percentage. This indicates the nurses appreciated that need offer warm and friendly care for mentally ill patient. Knowledge and training. This study evaluated mental health knowledge training among nurses and found 74.8 respond felt informed, although is high percentage. This is still means large proportion of nurses may lack efficiency in handling mental health cases, being professions dealing with the complex mental condition 51. Requires specialized training. It is address is the possibility psychiatric emergency and effective communication and treatment with patient. Impact of demographic or perception. The survey constitute attitude by gender, hospital type, experience, department, and area, and determined that they were no statistically significant. Difference between these groups be less than 0.5. The result, it was the first hospital must recognize the need for condition mental education. Second, hospital policy should be revised and incorporate mental health awareness program. Third, the mental health care of nurses themselves must be give priority. Stress, burnout, and second trauma are high among many nurses, practically nurses who work with psychiatric patients. In conclusion, overall, this study highlights that newly qualified nurses generally have a positive attitude toward mental health patients, but the stigma remains as issue. Training critically a role in shaping perception, and nurse experience strong willingness to learn and improve their skill. And also the finding suggested that educational level and exposure to mental health training significantly impact attitude, reinforcing that need comprehensive mental health education nursing program. Improve mental health care in hospital and professional development, address stigma by fostering culture, expecting and understanding healthcare, providing can ensure that mental health patients receive comprehensive and highly care of adverse. Recommendation, it will be practice suggest beside this study finding, include enhanced continued training program in mental health of nurses, integrated specialized courses, nursing curriculum to reduce stigma and program, deeper understand of mental health, improving the work environment offering, psychological professional support of nurses working with the mental health patient, and organize awareness campaign in hospital to combat stigma among healthcare professionals. Thank you. Thank you for you and any questions.
Maybe done. Question?
Thank you, Mr. Roa. I pronounce your name is Roa.
Roa.
Roa, yes. Thank you. But if we don't talk about the problem, we are not going to solve it. And it is from experience. You know, as a Saudi physician and working for care more than about 30 years in healthcare. We have now a growing number of Saudi nurses. They are well qualified, but a good part of them, we have to teach them the behavior toward patients, actually. We have to talk about this problem, otherwise it will not be solved. I witnessed 2 weeks ago the dialogue between one Saudi nurse and the daughter of one patient in a leading hospital in Saudi Arabia. The daughter was telling the nurse, my mother is in pain and so on. She was in the ICU. And I don't know, out of frustration, I took what happened to this. She said, all of a sudden, code white. You know what code white means? In some hospital, code white means a bomb threat in the hospital. All the administrator of the hospital, all the security, all the people came into the ICU. Why she said that, I don't know. It is not only mental health. In general, we have really to talk about the problem in you behavior. Is my message actually to our lovely nurses in Saudi Arabia. Thank you.
Thank you, sir. And that's really what we see, and this, as you said, it is behavior and emotional. As we are staff and and our colleagues in the hospital must be all the time, we hear, as you said, where Dr. And because often we have a pressure and maybe come burn out from WC, from now transforming, and all that one, it can, but we are here. Because I am an educator, all the time I see, I said for our colleagues from nurses, we are all, we will be complete others. Not we are here, just what we have missing, we are here to, we will try to educate, mentorship, and coaching what we are going, but we are, all of us, we will come to support, because if it's successful, it will be all of us, we are successful. Thank you. Certificate.
Okay, guys, we're about to go to coffee break, but first, we're gonna come on stage and take a photo. And then we're gonna go for a coffee break. We're gonna take a photo out there as well. And then we get about 15 minutes for us to mingle and eat a couple snacks.
Yes.
Nice to meet you.
Yes, that's almost. Is your wife doctor?
Сколько лет в переводе как это вместо Трампа Джо Байдена кто-то выходил тоже? Да. Сейчас я посмотрю мой слайд, где Comments, Martin? Why comments? Why comments? No, but maybe. Okay. No, maybe comments this version. Okay. I'm. No, maybe. Ah.
Okay, give it here.
Okay. 1 minute. I send two version. Comments or no comments. What?
This one?
Uh-huh.
Should I copy?
Free copy.
Or do you want me to open first? Okay.
Huh?
I want to check.
Maybe this.
So standard.
Yeah. Okay. It's good.
Okay, copy.
Хорошо, что я проверил. То, что я скидывал с моими комментариями, там не было. Сейчас я скидываю. This. Maybe. What was okay. Close.
Yes, you can close
Okay.
this. Is it
Okay. All this. Okay.
Just rename it.
Okay. This is very good. Okay. Thank you very much. Very much. Идем в кофе.
Oh, yeah. Some people. About
Thanking you. Sorry for bad timing, but probably I will leave early because then I was so tired. Just if we go and sleep. Just like every day wind up and go and just like I would live honestly sleep somewhere anymore. I have to be with any kind of story. And then you can. The technology is not their structure that really doesn't or it doesn't just boring me. You don't have to check. There's no great for only reflection. Neither sleep, that they not feel strong. And this is totally not already saying really needed. Then we try to they want to have to do when you read The time also abandoned, that was jamming the lots of people. You take business from that. You put the force of having a fiscal terrorist, if the delays the case could get where the She's pretty sweet. He's living in when it will get married. You know, and so that's why she finished the education, she's doing some legal assistance at home. It was in some. Well, then pick her up. I've seen all this stuff. The treatment we got, all of this something she's treating her level with, I mean, more easy. If you see, she's going to find 8K now. They just don't have anything about us. I accept your question. Yeah, that's a question. She makes some testing and she might invent. She made being tested. Usually in the case when treated guilty Hendrix very due to this one that is more very and the experience of standing from that. I mean, she had good Gastroenterology while that thing is making both was she they made some in yeah, that's another. There is only so what that they do also I answered them with that, and they will relieve me. I hardly get home. Sunday. I'm just waiting to like to then I know some communication with my sleep and I hardly get home. Thank you. I understand exactly. Thank you so much. Thank you so much. I'll just take a couple of minutes of and then I will. Thank you. Thank you so much. But even as a coach, yes. Okay. One complaining is that we get very well friend, very about the kind of the purpose of my people. Really less question into very much. First question can go and read that the only big more than I mean very good in those questions. You know, the lines and it's very close to the and so we say that fucking people like that. It can switch up. Then I want to break up this barrier, it's safe. Then on the regulation of them, really be able to create my stuff bread, and then I'll speak with it. So there was my computer. After a data, that was very clear. So this is fun. That's why our rule is you can't see it more than 7. So what's so wrong? You think really about that? I mean, if you want to be talking about it, I don't know if you do. So sensitive. And I mean, anything is not a straight. Anything in this system, anything, they make it like all everything. Like I'm so worried about the typical they can be people this time. They have to speak. So we get out of that. And you know, this is this is actually giant food changes. I did it. I didn't be aware. I should definitely I'm doing how to get it. So I will be there in just maybe up to the next picture, because I'm trying to get well. I haven't the friendly film, a good from some off. And yeah,
When I'm okay, I think I'll be helpful. Thank you.
Okay. Guys, we're getting started again. Hey, everyone. Is Dr. Desokan here? Okay. So Dr. Desokan from the United Kingdom, and his presentation title is How to Develop Innovative Solutions to Unmet Clinical Needs, from patient to the laboratory, back to the patient. Please welcome Dr. Desokan.
This one, 18, 18. So, Salaam alaikum. Nice to see everyone. I've thoroughly enjoyed it from yesterday, and I will be starting my talk now. So, back to the show.
You need to do this one.
Where is it? It's meant to be like a triangle.
Do you need this one?
Okay, let's use this one. Stop.
This
It's even extended.
No, it's fine.
Okay. So, the title of my talk is From Patient to the Laboratory Back to the Patient. I would indulge you to just briefly quickly go through. So, probably have to do that with them. Still not. Because if you press this, then it works. And then we can go from there. Yeah. So my background is a bit of a skewed one, not a trajectory you expect from people normally. So I started from medical school, but very early on as a teenager, I knew I wanted to be into drug discovery and drug development. So started medical school, did my F1 for 2 years, then went on to do a master's in Glasgow on clinical trials, just to learn how to develop clinical trials, because I thought it's really going to be a big part of my future, and you see it when we talk through what we were trying to achieve. And then the PhD in therapeutics, where I met people like my good friend here in the crowd, and the idea is to start to learn how to use different delivery methods to develop problems with unmet clinical need. So back in 2017, when we started, I created a pyramid. I felt the easiest things to develop are OTCs. Over-the-counters are very easy. You can get them registered in 2 weeks. But then if you show a traction and you show that you can actually run proper trials on these things and you prove they work properly, the next line you go to are the wearables and the combination therapies. And then you can go into the big things, which is AI. So when we started, we created a consortium in South Africa, very interesting what they do. So you and I know that thousands of drugs have been approved. So for example, we went into the anti-infective space and picked anti-malarials, and we got like maybe 20 anti-malarials, turned all of them into gel, and we started trying them out on melanoma. And we got some hits for something which we think in coming years to come, maybe 3 years to now, we might potentially develop a new agent that we will repurpose. So the idea is that if you want to start developing something new to take you 10 years, it will cost you 1 billion. So why don't you just go to the shelf to pick things that are already there and you try and repurpose them for a new clinical indication? Now, the two focus, the way I think and the way you work about this, is to always make sure there is an unmet clinical need. Dementia, the drugs in the space right now, they're just scratching it. They're not doing anything really. Diabetic food, NHS where I come from, the UK, I don't know what happens in the Middle East, but we spend about $3.4 million a day on diabetic food. And we still, you just have to try and see if you can pick the drugs on the shelf, change the way you deliver them, and see whether they can make changes to unmet clinical needs like dementia, like diabetes and all the food and all the likes. So, like I said, we wanted to start with the small hanging fruit, and we started with back in 2021 when COVID came into the space. We thought we are not going to make the next Paxlovid, we're not going to make the next Molnupiravir, but we created something called COVID Recover, which was trialed in the UK September. It came back with 96.7% efficacy in taking away flu symptoms in 24 to 48 hours. So this is just something you get as an effervescent tablet drop in water. Take one in the morning, take one in the night for 2 days, and by the third day, you're up and running about. That's one of the first inventions. The next thing we did was, I'll show you a graph shortly on why we thought we needed it. So when children have fever, high fevers, you give them paracetamol. In the UK, the standard is we give them paracetamol with ibuprofen. But what we realize is 4 hours down the line, the temperature still keeps going up. These kids are still so much in distress. They're still so much in discomfort. And that's why we created this. I'm going to show you a graph soon, shortly. So, like I said, why do we need it? Despite the use of paracetamol and brufen, we still found that our kids remained distressed, they were in discomfort, their mood was not great, and we felt we needed to do something. So what we created is a cooling hydrogel. How it works is when an hydrogel comes in contact with it, it evaporates the heat, take the heat on, and it's as if you're taking the heat away from the febrile child. And then that kind of thing. I'll show you how we went about to do this. So this graph, when we did the first human trials, the blue line is the patch. You can see it didn't make so much difference in terms of temperature. The red line is your conventional antipyrexics, which temperature 40 degrees, 4 hours down the line, that kind of thing. But I'll show you the next graph. So this next graph is far more interesting. What we did with this next graph is the red line is paracetamol alone. So if you look at that, what happens is you have a steady decline in temperature, but then by the time you get to 4 hours, what we saw was that the fever started rising again. When we did with 5 patches, which is the green line, what we found was that into 8 hours, the temperature was down. The kids that had paracetamol, brufen, together with the patches, by hour number 2, the mood was elevated, they were running around, and as a parent, you feel better. You don't want your kid all flat and not moving around that much. So fever itself is a good thing. You want a child to have fever so that you know what to treat and what you're treating. But the problem is 4 hours down the line, you would have tried both paracetamol and brufen, which is the standard of care in the UK. If you do that and you still find out that there is nowhere else to go, you don't want to overdose these kids. And that is why this potentially can be an adjunct. After you use your paracetamol and brufen, you try and lay on 5 patches. And there's a chance that the way the data we've gotten has shown that this is more beneficial and the fact that you will have a better response. So, like I said, all we work on is unmet clinical needs. So we thought we were going to the dementia space. We created, it was just, when I thought of this idea, and this is where the patient to the lab to the patient idea comes from. For the flu, we felt we needed something extra that is easy for people to buy over the counter. For fever, we saw that 4 hours down the line, give paracetamol, brufen, these kids are still not well. And that's why we did that. For dementia, all the cholesterol inhibitors and things like that in the space, they're just scratching the surface. We really, I think in the next 3, 4, 5 years, more and more new drugs will be approved in that space. And we hope it's going to get better. But for me, how I got interested in this is the fact that I realized that when I was in the clinical space, when I see demented patients, they came with a higher rate of constipation. So back in 2019, even way before brain gut axis became a thing, I thought there must be something here. So we created something that would help them move their bowels better. That was how we started. And then from there, we went on to check all the big biomarkers. Like that's the unmet clinical need in that space. But then the theory is that there's a brain gut axis that they communicate with one another and they contribute to the pathogenesis of dementia. And when we did do this, what we did is we got all the relevant biomarkers in dementia space, beta amyloid 42, phosphotal 181, homocysteine, IL-1, cholinesterase, BDNF, NGF, and all the likes. And we realized that if the oral probiotics outperformed donepezil, mametil, and all the drugs we had in dementia space. We also did the behavioral test. This slide is particularly quite interesting. So we dosed some animals with the probiotics, we dosed some with donepezil, we dosed some with mametil. What we realized, and we dosed some with scopolamine. The scopolamine ones had very severe neurodegenerative changes. That means we're practically damaging the brains with what we're giving them. The donepezil had mild changes, but the probiotics at 250 and 500 milligrams per kg, the brain cells, the hippocampal area was all cleared, which from everything we've done, we checked the liver, the kidney, and all the other organs, plus all the blood tests we've done. This is shown to be quite safe, and we're quite excited about it. We're hoping to see what it does when it gets to the clinical trial space. So When I started my introduction, I talked about the fact that we have a production line in South Africa. And what they did is quite interesting for these two cases. I'll probably start with the Lipitor. Many of people in the crowd, maybe more than 50 people on Lipitor, what happens is 20% of these kind of patients wake up in the morning with very severe myalgia. So what we did was quite clever. We got a new drug that is repurposed drug that has already been in market for 50 years, and we added it to Lipitor. And what we found out in the trial was that 20% of patients that were on Lipitor alone still had the myalgia and arthralgia. But if you add on the second drug to it on the day 3, what's happening is the myalgia and the arthralgia becomes negligible. For TB, what we did was we repurposed another drug, adding to the 4 cocktails. I don't know what the TB rate in Middle East is, but in South Africa, where it's done, they had the hotbed of HIV, so they had a lot of TB. So what they did was, Triaham had the 4 drugs, another one had the 4+1 repurposed. The 2 things they saw that was remarkable, rather than be on treatment for 6 months for TB, those that had the 4 drugs plus the repurposed drug had 3 months of treatment and they got well. Those that had the 4 drugs still had a lot of extra pulmonary side effect, whereas those that had the 4 drugs plus this 1 repurposed drug did not have that much extra pulmonary effect. It is something we're going to publish soon. We're still working on the PO, and when it's done, we will publish it. So the success story so far, we've had 2 OTCs ready for launch. We have 5 open to launch. And to any conference I go to, I always look out for people, more clinical trial sites. We've done this in the UK. We've done the trials in America. We've done in Africa. We're hoping we want to do trials in the Middle East as well. We have so many things coming in the pipeline, especially the repurposed ones. And we're hoping over the next 3 years, we'll get them into trials and see what we make of them, especially in the MENA region as well. We want to be part of what happens out there to try things and see, we'll get the ethical approval and get everything done the right way to get them done, and we'll take it from there. So in essence, the summary of what I presented is that when you start from actually looking at the patient. That is the way we work. So what is there that is a problem? Patients on Lipitor, which is the gold standard for hypercholesterolemia, they wake up every morning with very bad muscle aches, with very bad aches. And by adding a new drug to the Lipitor in a combination pill, what we're trying to take away is to take away that muscle ache, to take away that. We're looking at the space of dementia food ulcers. They don't get killed. They don't get treated. They're there, and we keep throwing antibiotics at them for 10, 15 years, and we're still on the same spot with them. So I think we need to think outside the box to see how we can work this out and improve the care in that space. Dementia is another one we're working on. And if we can also improve care in pulmonary TB space, it would be great. And hypercholesterolemia as well as the other things we'll be doing in coming years. So the idea is, as a clinician, start from seeing what is the defect, what is the unmet clinical need, how are my patients suffering? And from there, go back to the lab to try and create a solution, and then go back to the patient again and run a small phase 2A trials. If it works out, then you do a bigger trial, phase 3. And if everything works out, you go to FDA, go to MHRA, go to the Saudi and the UAE authorities to see whether or not you can get this product license. It just seems to make the world a better place. That's what we do. Thank you very much.
Thank you very much, Doctor. From yesterday, probiotics, till today, you give hope to the people actually. But are those studies RCT? Secondly, are those remedy? There is remedy for everything now we're talking about. Is it approved? We have here pharmacology professor, we have all these scientific people. Are this drug, are they approved? Like if they approved, because if they are not approved, we'll take them only like this. You know, probiotic is expensive. And this is now obstacle for the patient. Now there is insurance, and the insurance will not pay for that, the hospital. are there any steps toward getting this approved that insurance companies accept that?
So I'll start from your approval question. My list of collaborators, my good friend is in crowd, Professor Mohamed Obai. I actually have Professor Van Tang, who led the COVID response in the whole UK. He's going to lead the trial that flu thing. We've done the first set of trials, but we want to do a larger one. So my background keeps me in check, and I know that if you dare do anything that is not ethical, you're going straight to the jail. So you have to do it right. So my background keeps me in check in the context of the fact that everything I presented are pretty early data. The only thing that are probably good to go is maybe the fever patch and the flu OTC. But most of the other things we're doing are going to a large phase 2A trial and a large phase 3A trial. We're not there yet, so they're not approved yet, but we're getting there. We've gotten some. So, like I said, the way we work it out, the small population trial first gives you a snapshot idea of where you're going, whether this is worth your time, whether you should invest more in it. And those have done very, very well. And we think it is now worth it to take it on to the bigger trials. But also on that list, I have Professor Elder Multiple. She's the biggest neuroscientist in the UK, as far as I'm concerned. She has some very fantastic models that can tell you mechanism of action of whatever you're doing with. We're working with her in the new year to advance and take on this product to the next level. So we're still working on it. They're not approved yet, but we're in the process.
Thank you.
Any more questions, anyone? Hey, Don.
Thank you.
Please join me for your certificate. Okay, our next speaker is Ms. Kunal. Okay. From India, and the title of her presentation is Knowledge and Awareness of the Role of Speech Language Pathology in Cognitive Communication Disorders Among Nursing Professionals. Please welcome Ms. Kunal.
Good morning, everyone. All are awake? Yes? I'm a speech language pathologist, so communication is a big part. I know it's a presentation, but let's take it as a conversation. Okay? Yes. So, a little background of mine. Before that, let me thank the organizers and Luciana for the wonderful introduction. And it's a privilege and pleasure to be here in front of all of you. So, I'm from India. I'm working as a speech language pathologist and assistant professor for the past 5 years, and I work on individuals with communication issues. So my topic is very simple, okay? It's not very complicated, and I've heard wonderful topics. So I hope you keep the expectations low, but then I hope that the message I deliver is important and you take it seriously, okay? So let me introduce my field a little bit, because I hope there's no other speech language pathologist in the floor. Yes. So I'm a healthcare professional who assess, diagnose, and treat disorders related to communication, cognition, swallowing, social communication, and communication after neurological injuries. Now, when it comes to communication, okay, there is speech and language. So, in speech, can all of you make some sound? Any sound? Let it be E, yay, anything. Just some sound. Let's make some noise.
Wow.
Wow. Okay, good. Yes. Now, this simple gesture. Now, we take communication very lightly because we are able to do it so easily, right? But the moment you say you know that there are 5 subsystems that works. Okay? So, in order for you to just say a word or a sound or just an okay, or even just to scream out, okay, you have 5 subsystems right from your lungs, which is the source of energy, right? So, you have your aerodynamic energy coming from your lungs, which is converted into acoustic energy by your larynx. You can touch and feel your larynx here. You have two muscles which converts the aerodynamic energy into aquatic energy. This aquatic energy is then transferred into vocal energy, voice energy by your articulators. Now, some of you said ah, some of you said wow. So based on what you want to speak, what you want to say, your articulators would change the orientation and make different sounds. Now, in order for all these articulators, the subsystems to work, you need your brain active. So your brain centers several neural connections work in order to make all these subsystems to work together to say and also the language centers. Okay, when I say language, it's not English or your regional language, your mother tongue language in general as code of communication. Okay, so this is my first time presenting in an international center, and I give this example of to my students, telling that if I speak to you in Chinese, will you be able to understand? Okay, and I hope some of you might understand here. And my students would say like, no, can't understand. Is it because you don't have the brain capacity to understand Chinese, or just that the language is not embedded in your brain, right? So we have languages, okay, and speech in order to get good communication out. So my topic within all those disorders, today's topic I have focused on cognitive communication disorder, which is nothing but a difficulty in communication due to the impairments in attention, memory, executive functions, reasoning, and other cognitive processes that support effective communication. Now, when there is cognitive communication disorder, it affects your understanding, your listening, your comprehension. Okay? When I say comprehension, listening, all of you are listening? Yes? Okay. Can you do a small activity? I'm sorry if I'm being too boosting. Is it? Okay, good. Yes. Can you all raise your right hand up? Can you show me the number 4? Can you all touch your nose? Oh, good listening skills though. Yes. So we visually representing it. You were so communication is not just your verbal modality. It comes with your gestures, non-verbal gestures. So most of you went and touched your ears, even though I said nose, because you were following my visual cue. Got it? So understanding it's not just language, it is the overall. Even your expressions, right? Yes. You might say a simple sentence like, I want to go there. Right? But your face is, I want to go there. Got it? Your intonation pattern, your facial expression would change the meaning of the same sentence. I want to go there. Understood? It's the same sentence, same words, same semantics, same grammar, but just your intonation and your facial expression change the meaning. That's the impact of non-verbal communication comes into picture with your verbal modality. And we have expression, we have problem-solving skills, which is affected in CCD. We have social interaction difficulties, and we have daily functional communication difficulties, right? So communication, when we talk about communication, the basic importance of communication is to be able to express our needs, right? To raise your voice. In order for you to communicate saying that I'm not feeling comfortable, or in order to just say no, language is very important, right? Yes. So this happens mainly because of most common disorders like you have stroke, which is leading to CCD, we have TBI, we have dementia, we have brain tumors, Parkinson's, cognitive decline, all these things can lead to cognitive communication disorders. Now, so since the focus is on nurses, my topic heading is all focus on nurses. Mainly why? Because they are the first line, the first voice, and the first listener for any patient. I hope all of you agree to it. Yes. So nurses spend most of the time with the patient when during the hospital stay, and they observe the earliest behavioral and cognitive changes. And they also are the first to notice any communication behavior problems or breakdowns. And they are the major bridge of communication between the patient, the doctor, the patient party, the caregivers, everyone. And also they ensure the safety, clarity, and continuity of care for the patients with any of these disorders. Now, why is this communication so important? During the hospital stay, can't we just stay silent? Why would it matter? The majority of importance when during a hospital stay to survive, to get down your disorder water for whatever reasons you are being admitted. But the lack of proper communication can lead to all these complications. It can lead to safety and fall of risk. Imagine a state where you're not able to lift up and get up and move from one point to the other. not able to communicate itself is a risk, right? And then we have medication compliance. So for a normal individual with active cognition also, we might miss out some medications here and there, medicines here and there. Because if there is a schedule, you're supposed to have this before your food, after your food, in this dosage. Even with cognitive other, we get confused. Now imagine an individual with some kind of cognitive communication disorder, they didn't understand what you were instructed. So just this lack of communication, lack of clarity for the patient can even affect the medication intake and their ability to follow instructions and interaction with the procedures. We do instruct. Any basic procedure, we do instruct the individual, right? The patients. Now, them not being able to comprehend and understand can risk the procedure, right? And then we have feeding and swallowing safety issues, where we as speech language pathologists comes into picture. So, an individual who has a dysphagia, which is feeding and swallowing problem, might create all these pneumonia-related, medication-related problems, okay? And for those also, we need the patients to be alert, to be able to be oriented to the instruction and follow the normal vocal safe swallow strategies, where communication again is involved. And of course, the length of the hospital stay also would impact. Now, there are a lot of global awareness gaps which is present, and there's a lot of study which says that there is high general awareness for nurses regarding those problems. Okay, but compared to the general disorders, their awareness related to the communication specific concept is comparatively less, which is again proved by another literature. It says that nurses in general lack the training because during their curriculum training, during their syllabus, this is not highlighted. And there is difficulty collaborating because if you don't know what else speech language methodologists can help you, won't be able to collaborate and won't be a part of the multidisciplinary flow. And obviously, there might be institutional barriers and workflow related issues. Now, how can we help? How can speech language pathologists help? So, obviously, we work on individual with cognitive linguistic functioning issues. We help them understand their communication problems and their strategies to help them. And we help them for social communication and also swallowing. We also can help the nurses to understand what other strategies can be used with an individual with cognitive communication disorders. Help them, train them during feeding, help with the communication breakdowns, and we can also help them understand management strategies for all these problems, and can also be helpful in co-managing delirium dementia behaviors, which is commonly seen in most of the adult patients with any cognitive decline or cognitive issues. So we conducted a study to understand what is the awareness of cognitive communication disorders and their symptoms among the nursing professionals. And we also wanted to understand if they are aware about the role of speech language pathologists, and also to understand why and how multidisciplinary management is much better, or what is the awareness and knowledge about that also. So what I did was I took 87 nursing professionals who have more than a year of experience and who are working with individuals with neurological disorder and cognitive decline. So I made a awareness tool, like a set of questionnaire, and there was an interview conducted with all these nursing professionals to understand how they manage it and what is their level of awareness. So post that, these were some of the questions that was included. Again, awareness regarding the conversational difficulty, the confusion, the capacity of the judgment, problem with the orientation of individuals and all that. Obviously, with the experience of nurses and with their training, they were able to identify most of the symptoms. Okay, in general symptoms, like they were able to understand that the individual have difficulty of talking, the individual has some disorientation problem. Okay, and they were also able to understand there's some confusions in patients, but was not able to understand or pick up what exactly is the confusion or what exactly is their problem. Is it an understanding problem or is it a cognitive decline? Is it a general confusion or is it just that they are not able to understand my language? All these were not clearly identified. And obviously talking related problems and voice related problems was also not guided because it is not their core area. We are not putting them out, but then since it is not their core area, they are not specifically trained for it. These were the factors that we found to be lacked. And overall, we understood that only 80.2 were involved in CCD as a multidisciplinary care. That means they were not a part of a multidisciplinary team that works to highlight and to uplift an individual with these disorders. So very few recognized SLP's role as well as considering them as an essential team member, and these results were very consistent with the global trends of literature. Now, why these gaps matter? So there are a lot of literature which says that the early you diagnose language disorders, cognitive decline, the high rate of prognosis would affect. That means if you are able to diagnose an individual with CCD during the earlier stages of a stroke, maybe within a week, within 2 weeks, okay, the faster you intervene, the faster you start with the management, the easier they get higher prognosis. So the lack of these responses, nurses being the first-hand individuals to intervene and to communicate with this individual, them identifying these disorders, we can start an early diagnosis and we can start an early management. And also, the unsafe feeding and communication practices can be completely eliminated. So we are reducing the chances of pneumonia. We are reducing the chances of them getting a complicated lung issue or swallowing issue and them prolonging in the RT field, which is very uncomfortable. I work with individuals from oncology, work with individuals with gastric issues. Also, the RT is not comfortable at all. So removal of the RT, the feeding tube is also a part of communication and as a role of speech language pathologists. And behavioral escalation and increased workload on nurses. I'm very happy that all these topics were already taken by wonderful speakers, and we have leaders like you to listen and understand the problems. So the workload on nurses, obviously. So for example, I am doubtful whether this patient have understood my instructions. Okay, if my workflow is easy, if I have time to sit back with the patient to ask, did you really understand my instructions? Can you show me again what I instructed? Okay, that would create a difference. But on the other hand, right now what is happening is nurses with their increased workload, they are not able to spend that much time with the patient to understand what exactly is wrong. Okay, so this is again because of the increased workload. But if they are trained enough to understand these minor signs or maybe a small screening tool to see an individual and immediately refer them to a speech language pathologist who is trained to understand these communication problems, trained to understand these cognitive communication problems, and would be spending the patient time with the patient to jump from there and state to a prognosis state. And obviously, poor patient outcomes is also another drawback. So what can we do? So from these, whatever data we got, we understood that it is very important to create training modules. Nothing very vast, very simple training modules, at least to identify what is communication disorder, what are the signs and symptoms seen in individuals, and how can we manage them. And it is very important to create a proper referral pathways. Okay, I work with a multidisciplinary team and I know the difficulty of getting the referral at the right time. Most of the time I wish and I wonder that, oh, I wish that I could see this patient last week. Because it takes almost 2-3 weeks for the doctors and the nurses to identify it and then refer them by the time the patient would have already got adopted with these problems. And in the professional training simulations can be created and a ward level communication tool. Since I work with a lot of ward patients and back in India, I don't know whether you're aware or not, because the patient load is very high. So, in order to create a good quality of life on an individual, especially during the hospital stay, it is very important that we focus on all this. So, I would like to conclude that from the study, so there is the findings, what I found from my study is very consistent with the global findings. So it is very important to strengthen the CCD literacy and it would definitely transform patient safety and care quality. So I would like to conclude my topic by telling that when we help a person to communicate, again, we don't just rebuild speech, we rebuild identity, safety, and human connection. Thank you so much.
I start because of my knowledge. That question because of my age. Age-wise, I'm the eldest in here, that's why I start. I have the privilege to start. Thank you very much for that. That means, again, as Dr. Azena said, we should revise or remodeling our curriculum in nursing school, isn't it? What do you think? Because also I think India is leading in those things because maybe I think 15 years ago, some of the university in India, they included quality management in the medical school.
Thank you, Krishna. See, I am not able to say it from a nursing professional point of view, okay, but obviously I have discussed this topic with nursing professional because I validated my tool with nursing professionals. So, most of them initially when they were giving me suggestion, they were telling me that it is impossible for them to know these minor, deeper details of communication and language because they already have a lot of things to be done as a curriculum and there's a lot of practical things they are working towards it, okay. So then that's why it is important to include another professional who's trained and have a better and deeper understanding about this topic. So having basic awareness, as you mentioned, sir, is very important. It is important to include in the curriculum. Okay, but then at least having an awareness that okay, this is the disorder, these are the signs and symptoms. So let me just call an SLP to work on the patient. That itself is enough. Them knowing everything will be too much to ask for, I guess, considering the workload and the curriculum that you are already managing from the nursing point of view.
Thank you very much. But we are not giving the nurses actually time, enough time,
Exactly.
because of the shortages. The nurse, they are doing job. They shouldn't do it actually. It's job rather than the other things than nursing. This is our problem. Not only in the Middle East, even in Europe, in America, in India, everywhere.
Yes.
Thank you.
Thank you so much.
Thank you very much, Ms. Rashmi. It's very interesting subject, especially billionaires.
Thank you.
My question may be, do you have any tool that we can easily use for the patient instead of learning everything? So as you said from the beginning, we could identify the patient and refer to the proper treatment.
Yes. So, cognitive communication used to be under different backgrounds and different flowcharts, but right now we have separately made it, and there are screening tools available back in India. So, but then it's important to validate it in your locality. Because the signs and symptoms of the region might vary based upon tendency and what department that you're working with. For example, there's a lot of common symptoms and signs, right? For example, for stroke, the signs and symptoms for CCD might be different from dementia or Parkinson's. So it is important that there is individualized screening tool, okay, and there are a lot of developing in India. I hope that there are more individuals working with it. And all these screening tools will take max to max 5 minutes to just administer that. It may not be the patient be alert because you are interacting with the patient anyway. So you can even go back to your system and see whether did the patient gave me an eye contact when I was talking to the patient? Did the patient nod their head when I was giving the instruction? Or how was their verbal output? Whether they were able to recall where they are oriented or not. Are they able to repeat back what I'm telling? All these are minor things that we can do within a fraction of maybe 1 or 2 minutes. Within that fraction, you'll be able to understand, might not be able to diagnose exactly what is their level of severity, but at least you know that they need a respiratory.
Okay, so you mean to say it's already existing, the tools?
Yeah, there is already existing.
It's being used by nurses around the world.
Yes.
Thank you.
I don't know about using it, but then there are tools available. But it's important as we say the management, the kind of workload that we have, even spending 2 minutes might be difficult for them. But then if we create a protocol, like for example, when an individual is getting admitted, the initial period of time, we do check for their basic BP and their initial status and all. And with that, maybe we include this as a protocol, then it will go with the workflow. Sure. So that is much better, I guess. Thank you.
Thank you. Just a comment on these tools. Actually, because it's a difficult or it's a challenging when you use these tools in a country where it's multicultural.
Exactly.
And you don't know if your patient understand the language that you're using in this evaluation.
Right.
So what do you do in this case?
So what we do is, back in India, you know the level of the number of languages what we have in India. Even in the same locality, we have multiple languages. So whenever we create a tool, obviously we will standardize in a validating their language. It is very important that we cross-check that language barrier. For example, me asking an individual, what is your name in English, and them not knowing what is that particular sentence, and you're telling, the patient did not respond. That's not right. So what we have to do is we have to translate it to the mother tongue or the local language which is available in those regions and then use it. So language barriers are a big problem and we have to take that also into the consideration when it comes to CG. Yes.
Anyone else? Thank you, Ms.
Thank you so much for
Please
listening.
kindly join me for introduction of the presentation. Our next speaker is Professor Shiha from Dubai Medical University, and the title of her presentation is Integrating Modern Drug Delivery Systems in Phytochemistry and Herbal Medicine, Nanotechnological Strategies to Improve Anti-Cancer Natural Product Bioavailability. Please welcome Professor Shiha.
Assalamu alaikum, good morning. My topic is different as now I attended yesterday and also today. I found most of the audience from medical college or from nursing. I'm graduated from College of Pharmacy, and my field for the natural products. So today I will explain why now we want to discover more natural products. And also I will explain some from my research with my colleague for the enhancement the activity of natural products. I chose this topic according to the well-known fruit, which is pomegranate. And you will find many research about antioxidant and it can use for anti-cancer. But here we formulated this extract of pomegranate inside the soluble soup. So the content of this presentation, objective, introduction, some examples of herbal medicine uses the nanotechnology, and briefly about some types of nanocarrier, and then our research for the effect of the pomegranate extract as anti-cancer. Going to the objective, I am here today again to send a message. We have to again focus for the drug discovery from natural product. Why? Because the natural product is safe and with less side. Not only that, we have many YouTube about the natural product, but what is the evidence? What is the scientific evidence? Who will discover this scientific evidence? Us, as a college of pharmacy. So, I will highlight about the evolution of natural products. I will also highlight about the role of natural product in the development of new drugs, integration of the nanotechnology to the natural product, and finally, our research for the books. So going to the journey of natural product, history of natural product. When we say natural product, we put in our mind medicinal plants. No, the natural product coming from many things, not only medicinal plants, but also for algae, from marine, from fish. Everyone eat omega-3 fatty acids from fish. And from animal source, you know, we have very important perfume, which is amber, coming from whale. That's very important. So we use the natural product when in the time of COVID, what happened? From the beginning, protection by supplement. Eat more orange as a supplement of vitamin C. So the natural product present. And we have worked more and more for the drug discovery from natural food. Many records present in many civilizations. India, for example, Ayurveda medicine, Arab, Egyptian, Chinese medicine. So I am not talking for something which is not present, but it's already present. I focus for the herbal medicine. Herbal medicine, do you know, in most of the herbs or the supplements even have two metabolites. Primary metabolite, which we eat due to as a source of carbohydrate, as a source of fat, as a source of protein. And secondary metabolite. Do you know that the secondary metabolite produced by the plants due to stress? Even the plants has stress. Yes. Stress from the attack of insects, stress from the attack of animals, stress during the pollination, even attract the birds for the pollination. This is the stress. In this way, they produce the secondary metabolites, the antioxidant activity, the cardiac glycoside. In this way, they produce this metabolites. And this metabolite is very important as a science. We found that if we focus for this metabolite, we can discover many plants used for treatment of many diseases. Few examples which we know. Curcumin, many researches about curcuma. Not only that, opium, morphine. At the end of this this presentation, I can tell you how can synthesize heroin from morphine. Cocaine, natural. Penicillin, natural. Digoxin, natural. Vincristine, vinblastine, taxol, anti-cancer, natural. So, I'm only one using the nanotech knowledge for the herbal medicine, of course, no. We have many researches. That is just a few researches I mentioned here for increasing the bioavailability, increasing the pharmacokinetic, target the cells, increasing the stability. So here, like Muhammad and also the doctor always think about nanotechnology. So I will not again explain what is the nanotechnology. This is the nanocarrier type. Going to my research. This one is my team, Prof. Bazra, the head of the department, and my student Hoda. Here we formulate the pomegranate extract in the form of sphenosomes for treatment or for targeting the cancer cells. You will discover with me, and we use 3 cancer cells. For the method of pomegranate, first, if you want even to protect yourself from the cancer from the beginning, why we have to wait till there is cancer? We can protect ourselves from today. Many researchers say that about the pomegranate. Which one? When you go into the supermarket, you find many types of pomegranate. Always choose the one which was red color, very, very dark red color. This very red color, due to it has a lot of secondary metabolite known as anthocyanin. And there are a lot of research about the anthocyanin have a strong antioxidant and also anti-cancer. That is why we choose this one, the very red color. The second question, The seed which we eat has antioxidant or the pericarp which we throw. That is why I use both. Comparative study. The seeds, juicy seeds, and comparing with the pericarp. What is the meaning of pericarp? This is the outer layer. The outer layer. What we did, just separate the pericarp and then dry it. Then we use for each one, we use salt, water, and alcohol. Again, remember, it is comparative study. We wanted to know which one is strong. For any research, we have to make standardization of the extract. What's the meaning of that? If anyone wanted to follow or complete this extract, they have to choose the fruit which we choose, and then they have to know what are the amount of the bioactive compound, because we have very dangerous factor affecting the release of this bioactive compound, which is environmental factor. That is why before starting any research for natural product, we have to make standardization of the extract by many methods. By, for example, advanced technique, HPLC, LC mass, by measuring the total flavonoid, total antioxidant activity. Not only that, we also screen for the anti-cancer cells using 3 important cancer cells. First one, the breast cancer, which is common for the woman, cervical cancer, also common for the woman, and colon. What is the relation between colon cancer and cervical cancer and breast cancer? Many researchers say that sometimes about 10% from the woman suffering from breast cancer, after 10 years, it can be changed to the colon cancer. That is why we focus for these 3 cancer cells. Then, after screening, after we know, after the comparative extract, we find that the most effective one is the pericarp. Notice, the most effective antioxidant, anti-cancer is the pericarp which we throw. So that we formulated as asfencosomes. Why? We want to increase the bioavailability, the pharmacokinetic, and the targets for anti-cancer. Of course, for any formulation, we have to make characterization. So we did a characterization by the FTIR, the bioavailability, the release time, all of this we did it, and also under the microscope to understand if our extract incorporated inside the capsule or the particle or not. We went in vitro. That is why I told for anyone can complete our research and we can collaborate, make a collaboration together because our research for in vitro study, not for in vivo. So we want to complete our research in vivo. Also, we use the MTT assay. Briefly, the MTT assay is depending on what? On the reagent. The color of the reagent is yellow color. When there is vital cells, whatever this vital cells, cancer or not cancer, what happens? There is reaction and forming insoluble matter, and this insoluble matter gives the particle. So, when we add our extract, what will happen? If there is inhibition for this cancer cell, you will find either the purple color change to the yellow color again, or you will find that the purple color become more faint color. Of course, our results under the statistical analysis, going to the important one, as I told you from the beginning, we have to make standardization of the extract. So we choose the right way. Antioxidant activity, we find that the highest antioxidant activity going to the pericarp. Remember with me, alcohol and water are only solved before going to any experiment. Of course, we evaporated the alcohol and we make a lyophilization for water because alcohol itself is toxic. Okay, so this is very important point. And only we use the alcohol or the water just for solubilizing the extract, the active metabolite, and then we evaporate it. Soon, this is a picture under the microscope. Also, we find that under the microscope, we make a 3 formula. We find that our extract under the microscope present inside the particle. Also, for the releasing time, we wanted to know if there is releasing time or no, or it is just kept the extract inside the capsule, and when the patient take it, maybe there is no release. So, as according to that, we make a 3 formula, and we found that the formula F2 is more effective. That is the anti-cancer under the microscope. How can we know there is vital cells or no? Remember with me, the vital cells reacted with the reagent, and it gives insoluble compound. Insoluble compound, it is like a crystal. So under the microscope, if we find more crystals, like that, there is no inhibition for the our extract. But if we find less crystals, we find that we have anti-cancer drug. So the evidence here, we have evidence in vitro study for the we can formulate our extract as asfentosomes, and it is good for delivery. This is the conclusion, and I want to. This is the one which I take it from our dean. Always our dean and vice chancellor use this one. The greatest danger for most of us is not that our aim is too hard and we miss, but that is too low and we reach. So whatever your age, we can always make a development. Don't stop your brain in the research. Thank you. I hope to answer your questions because my specialist is pharmacology.
Professor, you mean that I am an advocate for pomegranate. I like it. Also health-wise, I like it. But it is because the content of the anthocyanin is it also is antioxidant? Is it also anti-cancer?
Yes.
And what if we take the, you see in the shop, you will find the skin, the outer skin powder. Is it the same?
No, for my one, I don't answer. Say, because I have teacher by now. So, for my group, always for national product, we don't want any food paper. We have to be very from and our one, because you don't need dust. If there is dust, if what about what is about storage? There is something may be environmental and to impose this one. So even me, by the way, for the sorry for that too spicy, kill me. or black pepper or all of this. Never I blend the powder one. I always blend the fruits or the seeds or the entire, then I will do.
But sorry, doctor, how can we actually herbal medicine, how can we convince the drug industry?
Yes, very important. Very important. For the herbal medicine, we want worship and we want sponsor. That is why in some companies, especially in India and Egypt and Arab countries, also Chinese, they have a lot of response for national.
Because they believe
They believe in that.
Thank you. So amazing.
Question.
Yeah, we're running out of time.
Which is good.
Yeah, it's very
Otherwise, there's no comment. I comment.
Excuse me, everybody now in medicine is going to biosimilar products, and they are investing too much in the biosimilar. Now you are talking about the herbal product, which is way different from the chemical one or biosimilar one. So how?
The health of which I started by my business. That's very important. So I can put to that nature. Raise this one. We have many companies just for the synthetic drugs. How many side effects? How many now many synthetic drugs growing from the market due to this side effect? So why we don't start by this? Why we don't have this sponsor for our research project? Our research project here, it is starting. It is very easy to make in view, but where is the clinical stuff? Who will give us the budget to make the clinical stuff to complete, then to release the anti-cancer drug from the human clinic?
Same as the biosimilar product and the chemical product.
The chemical product and the biosimilar, I don't understand this one really. Biological.
Now everybody is starting to
This culture.
from the bacteria itself to produce even the insulin. Now they are.
Yeah, I know that. I like the example for that. Okay, so what is the response?
I mean,
this plan.
The treatment period for using herbal product and the treatment period for the other product is the same.
Yeah, very important question. No, always the treatment. If you take the natural product as it is without formulation of dosage form, it needs more time. That's a rule. That is why we formulate it. To give the same, right? I give a very important example, like digitalis. Digitalis is a plant. But we don't take the digitalis as a plant for cancer field. It is a digoxin, which is a polycyclic ferment in a cup. Viscopan has a hyoscine. This is also from natural. And we have to formulate it.
Yeah, I wanted to add something like as someone that works with oncology patients. Now we're talking about a trial that was made on cells, and pomegranate is an antioxidant. However, a patient coming and telling me he's drinking now 3 liters of pomegranate because he believes it's an antioxidant. I think we need to be careful about these misconceptions that we need to focus on the exact amount of pomegranate and concentration of it when telling a patient or anyone in the public, to make sure that we don't reach this level where they go to the extreme. Okay, now I drink a lot of pomegranate and then I'll be treated from cancer. And maybe as a prevention, as starting before even developing the disease, that we would be more in category of talking more about pomegranate and drink it a lot or add it to your diet more than as a treatment or may heal you.
Can I answer from this one? Please?
Yeah.
That's very important. I introduced in UAE one course, which is natural medicine safety and ethics. It is only here in Eden Gulf. I introduced that because I believe what you take. If it is natural, so it's safe. If it is natural, there is no interaction. Do you know that pomegranate has strong antioxidant activity and has strong interaction with the anti-cancer?
Yeah,
That is why the patient cannot take the pomegranate without the advice from the doctor.
exactly. But also don't forget the efficacy of the chemotherapy or any active treatment is affected by the amount of the body composition when talking about fat and muscle mass. So when drinking, let's say someone comes and drinks 3 liters of pomegranate, it is a high risk of either insulin resistance or gaining weight.
Yes.
And as a result, we may have poor results according to for cancer treatment.
For drug interaction. Because behind that, in pomegranate and the other, by the way, orange, do you know orange? Always when there is any anti-cancer, some taking chemotherapy, the immunity is decreased. Or even me sometimes I say to increase the immune system by taking flax seeds, by honey, by the vitamin C. It is wrong. When I introduced this course, I found it is wrong because the antioxidant can make a complex with the chemotherapy inhibits the action of the chemotherapy, which is wrong. That is why always we say that the natural know that it can be alternative and complementary. And so for this case, even we cannot use hand or chemotherapy because there is interaction.
I think we are too scared in the herbal medicine world. Bring it to my specialty is lung trials. And when you were talking, what struck me immediately is I could take your stuff to make it into a tablet and go to West Africa. What happens is if you have breast cancer, mastectomy is done. Afterwards, in the West, what we do is to put letrozole. We put them on letrozole to prevent it. That's what we do in the UK. I don't know what they do in the US. Now, Africans they can't afford letrozole in a place like Ghana, for example. So if you make that stuff into a tablet, we'll run it into a trial for 5 years, and then we will kind of like follow people up and see how many of them had recurrence in breast cancer. That is the way to make the claim. We can't continue to do all this study and not actually get it into patients. Let's get it into patients and let's really, really show if this efficacy is there.
The sponsor's here.
Yeah, I don't say sponsor.
Nice timing.
Thanks for that.
Thank you. Thank you, Michelle. Love it. Love it. As a dietitian, I support it. And yes, about how much the efficacy, how much it's too much of something good is not gonna be right. It's like the optimization, right? How much do we need for this reaction to work in the body?
Yes, okay.
Hey. Our next exhibitor is Mr. Rock Lin, the marketing director at Silvertech. And his exhibitor title is Efficacy of a Novel Channel Cleaning Bulk Brush for Endoscope Reprocessing, a randomized controlled trial. Please welcome Mr. Lin.
This is Moscow.
It's a slider.
Merhaba, and I wish you a happy new year. First of all, please understand, I am a 70-year-old Korean man, not good at English speaking. I'm from Korean company, Silvertech Ltd. As my company name shows, we are specialized in silver ion sterilizing products since 2002. But 5 years ago, we noticed the big market potential in the endoscope channel cleaning brush. Until now, most cleaning tool was this long brush. This is a 2.3 meter brush. But we have invented this tiny ball brush, just 4.2 millimeter ball. Let's imagine this is a tiny tennis ball. It cleans channel inside the wall more better than existing brushes. Oh. There are many market search reports, but one of them is verified research, market research, which shows 300 million US dollar by 2033. We have exact, We have exact data for our market. Our Ministry of Health and Welfare publishes National Cancer Screening Report annually. This year's report was based on 2023, and Koreans examined gastro and intestinal total 15 million examination was performed in 2023. It means this ball brush price about 80.7 million US dollar, quite a big market. Also, one point is this makes many medical waste, but our ball is only just 4.2 millimeter. We have performed many clinical tests and published on the 2022 clinical endoscopy. Clinical test was performed at 2 large Korean hospitals, and all data is we provided to this conference organizer. We have 3 types of balls, and shows structure. Silicone ball was covered with a very fine microfiber. Microfiber has many hairs and it covers the whole inside the wall of the channel. So cleans much better than existing brushes. Also, conventional brushes makes scratches inside the channel wall. United States National Institute of Health also 2023 report shows problems of these scratches. But we have much less scratches because of very fine microfiber. Also, conventional cleaning brush methods, it depends on the nurse's skills and proficiency. So cleaning result is varied per nurses. But our ball brush is only using suction motion. All the result is nearly same. It's our medicine. Maybe only a few people interested in our products, then we can provide all the data for them. So let's skip this one.
New concept endoscope channel inside cleaning method. We would like to introduce Easy Jet Clean Ball. The conventional method to clean the inside of an endoscope channel with a brush requires considerable physical labor and time, and may cause some scratches due to friction heat, which may result in a secondary infection because of cleaning difficulty. However, this Easy Jet Clean Ball, made with silicone covered with ultra microfiber, can clean the inside of an endoscope channel without concerns of scratches. Let's see how to use the Easy Jet Clean Ball. Put about 70 cc of water into a cup and soak the Easy Jet Clean Ball in it. Then, wait until the pressure gauge rises to 0.5. Put the entrance of the endoscope into the cup and then aspirate the Easy Jet Clean Ball after aspirating about 30 cc of water first. After aspirating the Easy Jet Clean Ball, aspirate all residual water and expose the entrance to the air. Then, after inserting the balls into the aspiration button, repeat these steps to aspirate the Easy Jet Clean Ball. After finishing all these processes, the number of filtered balls should be checked. This Easy Jet Clean Ball provides excellent cleaning power, reduces physical workload, and shortens cleaning time. Also, it removes concerns over scratches in the endoscope channel, maintaining cleanliness and saving on repair and maintenance costs. On the contrary, the conventional brush for cleaning the inside of an endoscope channel may cause scratches due to friction heat, which may result in proliferation of contaminants from poor cleaning. Furthermore, it requires considerable physical labor and time because it is necessary to insert the brushed line into the long endoscope channel.
Thank you for listening. Peace with you.
Thank you, Mr. Lin. Have enjoyed for your picture and your certification. Okay, our next speaker is Dr. Tahiri. And he's from Iran. His presentation title is Evaluation of Argon Plasma Coagulation-Based Anti-Reflux, Mucosectomy and Ablation, Technique for Treatment for Gastroesophageal Reflux, a case series. Please welcome Dr. Tahiri.
Thank you very much. Hello, everybody. Actually, I want to know firstly that how many clinicians and gastroenterologists are here? 1, 2, 3, 4, 5. Thank you. Actually, I didn't know about that. This is not a professional and subspecialty congress, and maybe it's a little specialized in the field of gastroenterology. I apologize to other people here if it's a little complicated. I simplified the slides, but I don't know how it's going. My name is Amir Tahiri, gastroenterologist and endoscopist from Iran, the head of gastroenterology department of Azad University of Medical Science. And I'm going to introduce the one treatment for gastroesophageal reflux disease, an endoscopic one named ARMA. It's anti-reflux mucosal ablation and mucosectomy technique. As you know, gastroesophageal reflux disease, or GERD, is a very common condition in patient of every gastroenterologist, and always it requires long-term pharmacological and lifestyle modification treatments. The global prevalence of gastroesophageal reflux disease varies in different parts of the world. For example, in the USA, it's about 18 up to 27% of patients. And in this area, Middle East, it's about 8-33%. It's a very high prevalence of a disease in the world. Actually, we have very different type of drugs that are very effective in the treatment of reflux disease, but actually we need to prolong the duration of treatment, because when we DC the drug, the complaint always recur. And the use of most effective type of drug in this category, named PPI or proton pump inhibitors, may have some complication like increased risk of gastric cancer and increased osteoporosis and fractures. As you can see here, some of them are very strongly related to the drug, like increased rate of Clostridium difficile infection and deficiency in natural vitamin like B12 vitamin, and also some kidney disease. And some are moderately dependent, like osteoporosis and increased risk, especially in the women, and also increase the rate of CAP, community acquired pneumonia, and also small bacterial overgrowth. Some like dementia and increased risk of gastric cancer and cardiovascular events are less likely to be related to these drugs. As I said before, the long duration of treatment need for treatment of GERD sometimes is related to these complications. Endoscopic approaches such as anti-reflux mucosectomy and ablation, named ARMA, using argon plasma coagulation APC, have emerged minimally invasive alternatives in this category of treatments. We performed an evaluation like a case series study. We performed the ARMA technique on 30 patients diagnosed with GERD, including 28 who underwent a standard ARMA, and 2 have received an extended version involving ablation with band ligator device also. We use argoplasma coagulator device, and as you can see, it's important to modify the power between 16-18 watts and the flow of the argon gas between 1-2 liter per minute. As you can see, in this patient, the patient has a moderate size hiatal hernia and reflux disease. We perform marking with APC like a horseshoe about 2 centimeters below the cardia. And after that, we extended the coagulation with this device like a horseshoe also. And this is the patient after 3 weeks, can see that the Patulus LES is completely healed and the hiatal hernia don't see again. The primary objective were to evaluate symptom improvement and reduction in the need of anti-reflux medications. Clinical outcomes were assessed using a visual analogous scale named VAS. And patient-reported symptom relief. Patients were followed for a mean period of approximately 3 months. Complete clinical response with minimal need for medication was observed in approximately 20% of patients, and partial response also was seen in 53% of patients. You could see also another patient here, the large size hiatal hernia in retroversion maneuver can be seen. And after performing argon plasma coagulation below the cardia, this horseshoe-like coagulation can be seen. And after the 6 weeks, you can see the hiatal hernia is very well and didn't see. 26% of patients reported no significant symptomatic improvement. The procedure was generally safe and well tolerated without any major complication. Sometimes mild bleeding or dysphagia after the procedure was reported. 5 patients experienced transient retrosternal discomfort radiating to the back for 24-48 hours post-procedure. The addition of band ligation increased procedure time and cost, but did not result in enhanced clinical outcome compared to the standard simple ARMA. Notably, male patients showed a slightly better clinical response than females. And this is my team in Fariklegan Hospital in Tehran, Iran. If I can play, you can see the procedure. This is the marking 2 centimeters below the cardia. This is the argon plasma coagulator. We perform marking like a horseshoe. It's for this reason that prevent from the dysphagia. After that, we extend the diameter of coagulation area. As you can see, an area with diameter about 3 centimeters was coagulated. Anybody performed this technique before and has any comment about that? As conclusion, ARMA appears to be a safe and effective endoscopic technique for managing gastroesophageal reflux disease in selected patients, offering meaningful symptom relief and reduction in a majority of the cases for symptomatic treatment. Further prospective studies, the longer follow-up time are warranted. And this is the 25th Congress of Iranian Gastroenterology that take place these days. This is my country, Iran, very near to United Arab Emirates, over the sea. It's a very beautiful country. I invite all of you on behalf of the Scientific Committee of Congress to participate in next year Congress in Iran. This is one of the palace of Tehran. This is the Isfahan, the Damavand Mountain, and the Tower of Azadi. Thank you very much for your attention. If any question?
Question. Is there a risk of the recurrence? And is it effective in silent reflux?
Actually, it's a new technique, and we don't have a very long time follow-up. So I can't answer you if it's possible to recur after, for example, 10 years later or no. But in the short term, it's effective. Actually, it's effective. We don't perform such high technical procedures for patients without any symptoms, as you said, silent reflux.
Thank you very much, Dr. Amiri, for this elaborative information. However, usually GERD patients are not exposed to invasive procedures unless they fail to respond to the conventional PPIs.
Yeah.
And actually, these side effects should just put in a rather sort of exaggerated, because for many years we have seen patients using PPIs without any adverse effects, very minimal, and only for those possibly who are taking double dose, very resistant to respond. Abdominal plasma coagulation usually it's a superficial, as I understand, and not any patient with GERD has got a hiatus hernia. The doctor here has just mentioned, majority of them is just weakness of the lower esophageal sphincter. So is it going to work with that?
As you know, the most important cause of gastroesophageal reflux disease is abnormal transient ileus relaxation, not hiatal hernia. It's also effective in this category of patients. I showed some patients with hiatal hernia, but it's also effective on patients with transient ileus relaxation also. And these days we are going to move from pharmacological therapy to minimally invasive techniques very sooner than before.
My question is, I know you talked about follow-up 3 months, but I want to know, your first, was this technique from you? Are you the one that originated?
No, absolutely no.
So my next question is, do you have 2 years, 5 years? I know it's pretty new, so I know you're not going to have a 10-year, but if tomorrow I have reflux, I will have to do something resolve because really, if you think about
We have some publication about 2 or 3 years. I read it.
3 years.
Yeah.
And they stayed safe through the 3 years.
Yeah.
Thank you, Dr. Amir.
Thank you.
First of all, I have a comment and then a question. You put me back to the 70s, you know, when I was studying German in Germany in Goethe Institute. The half of the students were Arabs and the half were Iranian. And in front of the administration, I was representing the Iranian and the Arab student there, and it was a very nice memory. Secondly, in your patient, did you identify those patients have Campylobacter pylori or not, or it is only you just treated them with R1 coagulation?
You know better than me. Eradication of Helicobacter pylori patient with care maybe worse the situation of the patient. We don't eradicate the H. pylori in the patient with only care symptoms. So it's not related to each other. Even eradication may worse the position of the patient.
Thank you, Dr. Tahiri. Please join me for your picture and certificate.
Yeah, sure. I'm here for taking picture with you.
And our last speaker before lunch is Dr. Lee from Queen's University Belfast, and her presentation title is A Novel Responsive Microneedle Platform for Reliable Drug and Vaccine Delivery. Please welcome Dr. Lee.
Everybody, hi in there. This is the last talk, and I'll be quick and I'll be as engaging as I can, and we'll head off to lunch. My name is Huan Li. I hope everybody can hear me without the. Can everybody hear me?
Everybody can.
Yeah, so I don't have to use the microphone. Sure, thank you.
Voice is very beautiful.
Cheers. My name is Huan. I'm originally from China, and I've been to UK 4 years now to study my PhD, and now I work as a postdoc in the same group and university. It's my first time land on this lovely land, and I really enjoyed my stay here. So it's a pleasure to be here and listen to all those interesting topics and share a little bit work that we've been doing at Queen's University Belfast. And the project that we've been working on is a novel responsive microneedle platform for reliable drug and vaccination delivery. Let's start with problems. During COVID-19, do you know that the vaccination rate for the developed countries is over 70%, whereas for developing countries, it's less than 30%. There's a large vaccination inequity there. Cold chain reliance and the need for trained healthcare professionals are the major barriers. There are a large group of population called needle phobia. Over 10% of adults and 20% of children cannot have vaccination because of the anxiety for needles. And sharp clinical waste cost 6 to 8 times more than general waste. And the needle stick injuries cost NHS in the UK, for example, over 100 million per year, let alone the psychological toll for the healthcare professionals. So which one would you prefer, a needle or a minimal invasive patch? According to the market discovery, patients favor the microneedle more than the conventional injections because they are painless and the minimal invasive. However, one of the company called Zusano in this field went bankrupt in 2022. FDA rejected their new drug application for a micro patch loaded with a drug called zometriptan for migraine. What they find out is that in the clinical trials, there's a lot of variance in the dosage that's been delivered through this route. So from an academic point of view, we think it's very important to confirm the correct use and indicate the correct time for patch removal between each individuals to realize the personalized method. So at Quince, we dedicated to provide a thermostable, painless, self-dissolving, and self-applicable microneedle patch. By thermostable is that from our result, when you load biologics and drugs to the microneedle patch matrix, they will extend their shelf life as compared to the just in room temperature. This facilitates the distribution of vaccines in underrepresented countries, such as in Africa. And then painless, because the needle patch are so tiny, they are too short to reach the pain nerves, so it doesn't cause any pain. This gives an alternative option to those patients with needle phobia. And then they're made of biodegradable polymers. They will be self-disruptive on a post-application. So there's no need to deal with the sharp clinical disposal. And then what we did in Quince, we've invented an indicator that's integrated into the microneedles. Through a progressive color change, they will let you know if your patch has been successfully applied and the correct timing for patch removal. We've conducted interviews by engaging with the key stakeholders in this field and also patients, healthcare groups. They are all in favor of this technology. I would like to dive a little bit deeper into the scientific point. As you can see from your left-hand side, the figure 1 is a conventional dissolving patch. They are commonly used in countries like Korea, Australia for cosmetic use. People would load hyaluronic acid or toxin to remove the wrinkles for skincare. And they will apply them on the skin, and then after dissolving, there might be some residue left in the skin. However, for our technology, it's a 2-layer microneedle. The first layer will be loaded with drug, with excipients or vaccine with corresponding adjuvants, and the second layer is insoluble, made out of polylactic acid, which dispersed with a dye that can change color according to the dissolution of the first layer. We've patented this technology, and it's been featured on the Q1 Journal of Advanced Healthcare Materials. Then we've tested this technology on 2 model drugs, fluorescent sodium and phytidextrin, which representing small molecules and macromolecules. The figure 3, image ABC, GHI, is the 2 model drugs before dissolving, and then DEF and JKL is the one after dissolving. In order to visualize the localization of the drugs, we used the fluorescence microscope. You can see them nicely situated on the needle shaft area, which reduces the drug waste. And then we've conducted the mechanical strength test to make sure that the needle patch has enough mechanical strength to penetrate the skin barrier, which the stratum forming. There are ex vivo aspects in our field, so we have to color because it's essential to correlate the needle dissolution with the color change. So we've conducted ex vivo studies and also ex vivo frank cell studies for permeation to see how much the drug is being permeated and how much is being left as the residue. And then this is the ex vivo study that I was mentioning we would put the patch into a porcelain, excised porcelain skin, and then visualize them under the microscope every 10 minutes, and then until it doesn't, that's the dissolution process. And then we will use the color meter to measure the color change on the backing to see if the color change is still within human eye perception. Whenever it finishes, that's the end point. We can see that the dissolution is nicely correlated with the color change itself. Then we've conducted some physicochemical characterization using DSC and TGA and infrared spectrophotometry. We would like to show that there are no interactions with the excipients and also the active API. And also, I would like to draw your attention to figure 14, which is the biocompatibility result of the system against the human dermal fibroblasts. We can see that all the excipients that's been used in the system doesn't affect the proliferation of the cells. And then we collaborate this work with Spanish hospital in Barcelona in their biological safety level 3 labs we've load anti-HIV peptide into the patch, and we want to see if the anti-HIV functionality has been inhibited during the manufacturing process. And just shows that the IC50 increase, but not a significant level. Then we've conducted some in vivo study to see how it works in real world animals. So we've divided the rats into 2 groups. One group, they will be wearing patch for 5 days to make sure complete drug delivery. And then another patch, we will be closely monitoring the color change. Whenever the color change stops, we take the patch off. And then we compare the pharmacokinetics and also such as the AUC and the Cmax, Tmax. There are no significant difference between the 2 groups. You can also see from figure 17, that's the histological analysis to show the biocompatibility of the system for short-term wear. Here's some publications we've had so far in terms of this idea. It confirms that this system is potential in provide a safe, reliable drug and vaccination delivery. I want to also give you a little bit taste of why we do this and what's the market look like. So the parental drug market is valued at $595 billion, and is will be grow over to $1 trillion by 2034. And the vaccination market is 150 billion, will be 150 billion by 2033. And also the microneedle market will be 9 billion by 2030. Here's a little bit introduction about the players in this field. You can see them distributed mostly in Asia, in Europe, and also United States, and some key players in this field. And then I've searched the patent owners and the top patent applicants. So Pfizer, BD are playing actively in this field. I would like to acknowledge the efforts of all the families in our group back in Northern Ireland. We are a small island, but our group is the largest group in the university, thanks to the kindness and also supportive supervisor from Professor Ryan Donnelly. And we're happy to collaborate institutions, universities, and also pharma companies to help bring their API vaccine to the market into a transdermal patch. That's me, and I'm happy to take any questions.
Is it also for checking the blood glucose level in diabetic patients?
That's a type of microneedle called a hollow microneedle. And for us, it's a dissolving microneedle. So it's different types of microneedle, but yes, there are minimal invasive biosensor, or the one you mentioned. And for us, it's more of a delivery strategy.
I have 2 or 3 questions. Thank you for that beautiful talking. My first question is, Scotland, where I come from, there's the Scottish SME. The first question they're going to ask you when you're doing things like this is, what's the cost effectiveness? So oral tablets, if you start doing microneedles, what's the cost effectiveness? That's my first question. I see you guys have done, my second thing is, see you guys have done a lot of things, animals. Would you consider going organoids? Because if you do organoids, it's going to give you more, kind of like in terms of your early data to FDA, in terms of efficacy and toxicity and stuff like that. My last question is, what we deal with most in life is chronic diseases. So I know the application of this was where it's going to be biggest in vaccines, but in terms of chronic diseases, are we looking at saying, I've looked at overnight, I was looking at a couple of papers like I told you, but then isoniazid, maybe metformin and diabetes, those kind of stuff. Are you guys thinking about it in the future in such a way that you think this technology, I'm not saying it's going to replace oral, the conventional oral we have, but could it complement it and could it be cost effective in Asia?
Thank you for your question. You've done a lot of work in the background. So the first question is cost effectiveness. I have to be honest that I cannot answer the question now because this is a barrier in the whole industry for transdermal drug delivery using microneedles. There's no guidelines for us at the minute, but my supervisor is working closely with USP, FDA, and also the British Pharmacopoeia to draft a white book trying to standardize and also the manufacturing. But I've visited 5 Chinese companies for microneedle production and also 1 German company in Andernach. There's no significantly added cost into getting this indicator into the conventional cosmetic microneedles. So I'm not sure if that answers your question, but it's a work in progress. And then the second question is that we've conducted the animal studies, and definitely we will be considering organoids to provide more substantial data for future research into clinical trials. And then the last question is what disease or what type of market we're targeting. It's a very important question. That's why I'm joining those conferences and also conducting surveys on focus patient groups to see what is the very emergent market need. There's our publications in terms of loading insulin for diabetes and also for also loaded with GLP-1 for obesity. But for us, it's a platform technology. And we've loaded both a large variation of molecules in this field. We published 300 papers on it already. So it's just a joint effort with collaborators and us ourselves. We doesn't own the IP of API. So we collaborate with people and help them to bring that to the market.
Thank you very much for the presentation. Actually, my concern is this microneedle. You said it is very superficial, it doesn't go deep. Is it going to deliver enough concentration of the medication in a band? Because you might need loading those up, which might increase the cost.
It's a very important question. I have a prototype here. So this is less than 1 centimeter square in round. And this is loaded with 15 microgram of polymers. So to answer your questions, depending on the potency of the molecule itself and also the efficacy therapeutic window that you are giving to the patients. For vaccines, the dosage doesn't need to be high because the antigen represented cells are very abundant in the very superficial layer of the dermal skin. So normally it will range from 15 microgram to 50 microgram to 100 microgram. So that's no problem with a single patch like this. But we've conducted some studies on high dose delivery. So the likes of infubertide, which is 90 milligram per day. We've using hydrogel forming microneedles to deliver that. So for hydrogel, we own the patent in Queen's University Belfast. It's a microneedle, but it doesn't contain drug at all. And then instead, there will be a reservoir loaded on the top. So whenever the microneedle insert into the skin, they will be swelling and creating continuous conduits. And then the reservoir will be continuously delivering drug to the patients, which will not be limited, the dosage.
So possibly you might not be able to use it for insulin, for example, because insulin is given a subcutaneous beyond the nerve. So
Oh, there are already some papers published by Oxford. They've conducted a closed loop microneedle feedback system. So they will be detecting the glucose level and also delivering the insulin correspondingly using a microneedle patch.
The microneedling is used for cosmetics, and the medicine used for it is considered not a sterile product. Does it, in this case, considered as sterile?
And she's asking if it's considered a sterile product, the microneedle. Can we use non-sterile medications?
That's a very good question. We are still conducting conversations and discussions into this field because as it's minimal invasive, people think as long as you prove that it's low bioburden, it can, because you don't, how many times you've had a scratch on your skin, but you never get, you never considering to take measures for it. However, there are also considerations from the regulatory authority. It depends on the design of the geometry and also the penetration depth. Yeah, that is it. Thank you.
Student of the 1-1. Do you think, or you mean we have a stronger immune response with low dose?
I mean, the depth that microneedle reach with the superficial dermal layer. So there are abundance of antigen-presenting cells, such as Langhans cells. They are a lot. So whenever we reach the dermal layer, a lot of those will produce enough immune response for the whole body.
But at the end, if we get rid of disposable of this, it will be, at the end, it will be cheaper, I think. It should be cheaper than disposable of everything. I think so.
Should this need diffusion test?
Diffusion tested, do you mean the permeation through artificial skin, or? Yes. So we conduct the it's called Francel in our field. So it's a transdermal device. So yeah, we did, and then we measured what's being permeated across the skin, what's left in the skin, and we also quantify the residue on the patch.
So this has been done for this program?
Yes, yes. Thank you.
Any more questions?
Very nice.
Please. Kindly join me for your picture certificate. All right. Well, this concludes our mornings. So we're gonna go for the picture outside, and then we're gonna go have lunch at the 365 restaurant, same place from yesterday.
Yeah.
There's so many reasons. And then, yeah, that's good. That goes the other way. Yes. So we're gonna
I think we struggle to communicate to this patient in just the one. What about how we get from complicated? That's conversations are close.
Let me change the slide. Just a minute. Is the one? Let us see how she doing work on it. Doctor? Sneha. It will look fine there. It just here it will not come full screen. It will not come full screen here.
It's the third one. The third one is light. It's okay. Before it
No, I wanted to have a full screen here. Is it possible slide here? Like this.
Yes.
Like this.
You can have like this also.
Yeah, like this. But
Here, you press here.
press it here.
Press here. It will come again like that.
Okay.
Oh, okay. So, please check if it is updated one.
Yeah, updated. Let me see. Slides.
Yes. Yes.
Yes. Yeah, you see. No, you will be going to do the conclusions. So you look at it. It's down. This is not like our auditorium. Yeah, it's not like. Yes, conclusion is here. Come up. Yeah. Because what I think, if it comes here, no, this we cannot.
Can I just
read it here?
Can I
So if
just
it
edit
becomes-
something?
Yeah.
Because reference spelling is
Reference, yeah. That is, yeah, to the change it. It's came in screen here. Screen came here. Yeah. No? Yeah, here if it comes, no, it is easy for me. I cannot read it from there.
I'll just display settings, duplicate. For just
It's not coming here.
yeah, actually I have disabled over there.
So you disable this. So if it comes like this, it is okay for me actually. It will not come here like this.
Yeah, it will come like this now.
No, yeah, I won't like this.
Yeah, it will come like this.
Yeah, so by looking at here also I can talk, na? Okay, and I have to change the slide notes. Okay. Pointer is there. Pointer is there. Otherwise here, this I can use it. Okay. No problem. What is that?
Done.
So you will do like this, huh?
Yes, it will be like this.
Mine is updated or what? I wrote UD, updated one.
Can you check if it's
No, this is not updated.
for you? It will come like this. For her, we have changed.
No, but the slide.
So this is not the updated one. Can you send once again to WhatsApp? Do you have
Flash? Flash you have? Yes. I know maybe I'll be having issues. That's why. But I sent. No problem. It's okay. I still have time. It's okay. They told it is updated already. That's why.
This one, which one? No, I don't know where I kept. No problem. I'll just check with the team and I'll update.
Somewhere I put. I'm not remembering where I placed it. I will sit here, Doctor. I will go to him. I will sit here. Then okay, you can say. Wait.
Title.
Yes.
This one I will copy it.
Reminding you is enough.
So I am deleting this one.
Actually, the discussion today was very nice. Yeah. Because I missed it. Yes. Okay, thank you. It's 41 slides. I have to go faster. Even we have to go fast. Anyway, we will just. Thank you.
Thank you, Ji.
This one, how to use this one?
Just next.
This one?
Yeah. No, this one. The
This
bigger,
one?
yeah,
The big one.
bigger button.
Right, so this one.
Yes. If
We
you
can
want to
use
go
both,
back,
huh? We
yeah,
can use both.
yeah, both
Yeah.
you can use.
Okay, thank you, sir. Is that cool?
Yeah, you'll do that.
Thank you. Yeah, new one.
Good afternoon, everyone. I hope all of you had a good lunch. Yeah. Okay. So after the lunch, we have our next presenter, Dr. Rabab Abdul Qadir, Dr. Sneha Pitri, Associate Professor of Community Health Nursing. Their poster title is Heat Resilience and Safe Outdoor Play in UAE Children, the New Frontier for Community Health Promotion. Please welcome Dr. Rabab and Dr. Sneha. Thank you.
Assalamu alaikum. How are you all? Our title today, inshallah, Heat Resilience and Safe Outdoor Play in UAE Children, a New Frontier for Community Health Promotion. So, can you hear me? Can you hear me?
It's lighter.
Okay, it's okay.
It's
okay now?
Is it green? We will give this mic. Do you want to hold the mic?
It's okay. No, it's okay.
I'll figure this out.
So our session objective today will explain the urgency and key determinant of heat resilience among children in UAE. We'll analyze the community and environmental factors influence the safe outdoor play, and we'll evaluate the UAE initiatives and innovations, and we will apply the evidence-based strategies by the community health nurse and schools. So as all of us know, climate change at both global and national level poses threat to the fundamental rights of our children. So our children, they have the right to survive, to achieve their developmental potentials. Half of the world's 2.2 billion children aged from 8 to 19 years old, they are living in 33 countries that deemed at extremely high risk for climate change. The safe outdoor play is essential for the children's physical, cognitive, emotional, and social development. According to the WHO and UNICEF, providing safe climate adaptive environment for play is important and essential and is a right for our children. What do we mean by heat resilience? Heat resilience is the capacity of the individual, community, and system for what? To withstand, adapt, and to recover from periods of extreme heat while maintaining the health, function, and well-being. At the human level, we need to have physiological tolerance. We need to apply protective behaviors. We need to access to the cooling and hydrations. And as the health system, we need to prevent the health-related illnesses and diseases. And we need to have proper design infrastructure. All of this to reduce the heat exposure and vulnerability over the time among our children. What do you think? Why? Why heat resilience and safe outdoor play is important among our pediatric population? Anyone is willing to answer? So as you know, physiological vulnerability of our children, they have faster metabolism, they are produce more heat while during the activity, they have immature sweat gland, they have high surface area to mass ratio, they have limited ability to self-regulate the heat and recognize the distress and identify they are having a problem, and they have the increased the risk of dehydration and heat-related illnesses. Among pregnancy, for the pregnant lady, the heat stress is affecting her. It can make premature birth, can make
low birth weight. It can affect and raise the maternal and neonatal risk and mortality, and also placental inflammation and reduced blood flow. What is the impact of heat stress on our child health? So we can have heat stroke, they can have dehydration, electrolyte imbalance, they can have respiratory issues as a result of heat exposure that is linked with pediatric respiratory problems, maybe from the dust, from the allergy and infection. It also affects their cognitive and behavioral impact. It can make them risk to develop pre-existing conditions and indirect harm. Safe outdoor play is very important for our children. It will reflect in their physical growth. It will support their cognitive and academic development. It will establish lifelong behaviors through promoting the healthy lifestyle and health literacy. It will enhance their emotional and social well-being and reduce the stress and anxiety. It will strengthen their immune function and overall resilience, as well as establish lifelong behaviors. طبعا to overcome all of this, we have a multi-approach pillar to community health nursing to enhance the child heat resilience and safe outdoor play for protect the children from the heat-related illnesses. Dr. Sneha will complete the multi-pillars.
Thank you, Dr. Rabah. Good afternoon, everyone. Here, I would just like to concentrate on the strategies. Now, these strategies, all of us are aware about the climate and the climatic conditions in the UAE. There are two important things why we should think about the strategies. First of all, we want to protect our children from heat-related illness. And second important thing is to promote the outdoor play, which is all of us aware that is vital for the overall development of the children. So it's one of the important aspects which we should be not neglecting. Now, when we think about the strategies, we can see that it's a synergic approach. We cannot work in isolation. As we know that we can have an integrating approach related to the school, family, and community interventions. As we all know, when the child is small, he is there most of the time with the family. Then he starts going to the school, and then he will be going into the various community activities. So it is an integrated approach and interventions. We should think how we can promote the heat resilience and protect our children from heat-related illnesses. Now let us see what we can do for. All of us are aware about this topic, but we feel that it's again very important in UAE. Then when we think about the strategies in the school, as we all are aware that every school here has got a standard hot weather policy, which is prepared under the guidance or the guidelines which are given by the Ministry of Health, MOHAP, and Ministry of Education. And the school will have their own policy. And this policy is not only related to protect the children, those who are involved in caring or who are working in the schools, all these policies are there, which is formulated. Now, when we think about here, I will like to talk about the children. When we think about the children, it is recommended that the children should play activities, outdoor activities should be done before 10 a.m. when the heat is not very concentrated, or it is, and after the 4 p.m. Okay, because in between the period is very scorching heat, and it can really lead to the heat related problems in children. Dr. Rabab has already mentioned why the children are at risk for having a heat related illnesses. So it is always recommended that we should plan activities, outdoor activities will be planned before 10 a.m. and after 4 p.m. where the scorching heat will not be there. Next important thing is always we should recommend, we cannot say that, see this in UAE, the weather will be hot always. So we cannot have that excuse that children should not have a play area. So it is recommended that in the schools, we should have a play area which is covered. Okay, so which will minimize the problem which are related to the exposure to the heat. Then another important thing is that the activities which we can promote in the children, because most of the time what happens, we cannot just give the excuse that it is hot, so don't go out, don't do this, because it is affecting the health of the children. And all of us are aware that especially in the UAE and all over the global, we are problems like obesity, diabetes is increasing, and it is affecting overall the screen time is increasing, and it is affecting the overall growth of the children. So we can promote the activities in the school with the covered parking, cover area. We can have a swimming, we can have dancing, we can have skating, which will motivate the child to use those energies, and outdoor play, like we can have those activities in the school itself. Then another thing which we can observe is it is always better to have a peer review, a peer education, like we can educate the children related to the simple measures, how to identify they are heat exhausted, how to identify that they need to drink the water, how to protect them from the heat exhaustion. All these things we can teach the children, and the simple way methods through the pamphlets we can encourage the children, and we can teach the children so that they will protect themselves. Always we should make them self-sufficient. When they know why it should be done, how it should be done, they will promote, they will do these activities, and they will protect themselves from the all these ill effects of the heat. Now, another important thing, as Dr. Rabab has mentioned, these children, especially, they are highly prone for going into dehydration very easily. So we need to, at the school level, we should have hydration stations, which will be at the many places. It should be there. There should be access for the hydration should be there. Then we can have a colorful water bottles, which attracts the children to drink the water, and other, not only the water, other liquids also, which it promotes and it attracts the children, so they can drink it, and it motivates them, and we can protect the child from going into dehydration stage. So it is in the school there should be facility for the hydration stations. It should be there. Then when we think about this, we can include the children in preparing the popsicles. It's not necessary that we can have the children can drink only water. Not necessary. We can encourage the various other types of fluids which are also energetic and which will supply the electrolytes also. Like lemon juice is there, orange juice is there, and even simple cucumber juice is there, which we can involve the children to prepare. So when they get involved in preparing themselves, they feel motivated. And it's a coordinated activity which we can plan at the school level. And when it comes in the colorful sizes, shapes, it is motivate the children to drink. And most important thing is that the children we should not encourage them for beverages, which I again find it is very common. Beverages are being taken to children. They prefer to have beverages, which is again one of the reason for the having a dehydration, and the teeth problems also are there. So we must ensure that they are promoted with the use of the fruit juices, fresh fruit juices, not the canned fruit juices, and like lemon juice and all, we can encourage them. And for that, we should educate the parents also what they should promote in their child. Then another thing related to the community-based strategies, what we can adopt is public health ambassadors and community education programs, because it's very essential. If you take the people who are working, some in the particular community, we can have volunteers, we can have simple leaders, we can take them help to educate and increase the awareness about how to protect the children and all over the community related to the prevention of heat-related illness in the children. So we can have ambassadors from the community itself. Then the urban greening, tree plantation, cooling centers, because the particular community has to take initiative. It is not only the government's responsibility to provide everything for the community. The community people in the particular area, they should come together, and they should have this plantation of the trees, cooling centers, then heat resilient play areas can be promoted by the community. Then policies for heat reaction plans and early warning symptoms. It's very important to educate the community, and every person in the community how to identify the heat exhaustion or heat stroke behavior symptoms in the children or and what to do immediately. That is very important. And this action, there should be facility where we can educate, and also if there is a problem of the heat stroke happens, where to take them. So those facilities must be available in nearby areas in every community. Now, when we think about, we have thought about the schools, what we can do, we have thought about the community. Now, let us think what we can do at the family-focused actions. As I have already mentioned, because family, where the parents, caregivers, and every member of the family is the most nearest person for the child. So they must be aware and they must be taking care of the children properly. Now, when we think about the family-focused actions, first is we should tell them how to stay cool. Then use of sun protection like scarf, hat, like everything. And most important is sunscreen ointment. Sunscreen is, they say that plus 50 SPF is always better. We should use when child is going to the outside scorching heat or any heat area he's going. We have to use that SPF plus 50 because it minimizes the skin irritation. And again, it is said that if the skin the child's skin is very thick, delicate, and if it is exposed to the sun, definitely it can affect the DNA. And in the long term, there are chances of the skin cancer is also there. So we must ensure that the parents and the family members are aware about all these protecting measures which they can take for the child to prevent from these illnesses. Then on hydrate, I already mentioned about it. It's very important. Child must be hydrated at regular intervals. Then clean clothes and cotton clothes, because most of the time, we those say that cotton is difficult to maintain, but it's very important that children should wear the common cotton clothes because it absorbs the sweat and it is easy, there will be less irritation and skin rashes also will be minimized. We don't want to go for the fashions. We see so many good fashionable clothes, but synthetic material. It will irritate the skin and it will increase the problems in the children. So we must educate the parents that the child must always wear the cotton clothes for the children. We should take. Then another thing which we should educate the parents and the family members how to identify the symptoms which is related to the heat exhaustion and which are the symptoms related to the heat stroke. I'm not going into detail about it, but we must teach them. And if heat exhaustion occurs, like child is sweating, nausea, then dizziness is felt, so what should be done? Or if the child's temperature is not coming down, okay, child is going into the seizure activity, confused. It's the symptoms of there is no sweating. These are the symptoms of heat stroke. So what immediate management has to be done? Otherwise, long-term damage to the brain tissue cells can occur and it will be a really problem for the children. So we must educate the family members related to how to identify heat exhaustion and heat stroke and what care to be taken. Now, along with this, UAE also in collaboration with the international agency, that is UNICEF, what we are all aware about for the children, they have recommended the Beat the Heat program. Okay, in that what this Beat the Heat program says that, first of all, we have to be aware of heat stress, how it occurs, then easily identify the symptoms, act. When we observe any symptoms, maybe mild, moderate, severe, we must act immediately. And according to the symptoms, whatever is there, we should be taking care of the child. Suppose we observe the child is confused, seizure, temperature is not going down, we have to take the child immediately to the nearest facility, healthcare facility. Okay, so this is in coordination with the UNICEF, this program is run in the UAE for the children. Now I will just talk about a few things about the progress and innovations in the UAE. In the mind map, what they have done related to the various government initiatives are there. Educational system, they have included in the curriculum. Community and built environment, where they built the various play areas, parks for the children. They are having a public health campaigns they are conducting. Technological products and innovations they are using to protect the children from the heat illnesses. Now let us see what UAE government initiatives and policies. First of all, is national awareness and policy.
like MOHAP, Heat Exhaustion Prevention Campaign. Under this campaign, every nationwide, they conduct the awareness campaigns for the families, schools, and caregivers. Okay, then weather alerts and safety guidance. In coordination with the meteorology department, every time the alerts will be given to the schools and the areas where the children are there and in the offices also. And accordingly, the activities will be rescheduled for the particular children. It will be rescheduled. And most important is UV rays. Protecting the children from the UVA and B is very important. I told you about the SPF plus 50 we can use, plus other measures we can take so that we can protect the child from going into the risk of other complications like skin crashes, cancer, etc. In relation to the school regulations, heat safety school policies. As I already mentioned, whatever when their alert comes or the heat index is high, definitely what they adjust their physical education activities according to the temperature, whatever is there. Recess timings will be increased. So when they increase the break for the drinking water or any liquids, so they encourage the children to give the break for that. And it is recommended that if the child is in an active stage of play, every 30 to 60 minutes, the child should drink some fluids. That is recommended. Okay. So all these activities at the school, outdoor especially activities, will be adjusted according to the heat index, which is there, which is always predicted, and that according to that, it will be adjusted. Then child focus infrastructure and community measures are taken. Under that, the shaded, every community, they try to construct shaded playgrounds, cool play areas, then misting areas. In many places in the UAE, they are constructing this so that children can go there. Outdoor play is motivated and encouraged in that particular places. Now, government in continuation with this, hydration and cooling stations, I already mentioned in the school, we must have proper hydration and cooling stations. Then another interesting thing which I observed, which like urban cooling initiative, which is taken like greening project in Dubai and Abu Dhabi, where they are going to construct a 64-kilometer area which will be covered with the trees. They are expecting to plant 1 million trees over there. And one important thing which I like in that is there will be place for bikers, for bicycles, walking plaza will be there, playing grounds will be there, and most important is there is no allowed vehicles are not allowed. So here we are used to vehicles only, we cannot walk. But in those lush green areas, they are planning to create, it is one of the biggest project which Dubai and in Abu Dhabi also they are planning. So it is a very good initiative which government is taking because they have realized the importance of the future generation which they have having in this country. Now, another with the partnership and innovation and future direction, I have already mentioned about the UNICEF. Then in the local, with the collaboration with the local agencies, NGOs, and the non-profitable organizations, they are promoting to create the areas where the children can play and have outdoor activities. Then in relation to the policy and environmental education link, health and physical education lessons. See, here what they do, teachers educate on dehydration, heat exhaustion symptoms, hydration, sunscreen, how to protect themselves. Okay, so it may not be included directly in the curriculum, but under the curriculum of the environmental science, these topics are being covered and the students are encouraged and taught how to take care of them and protect them from the heat exhaustion or the heat stroke. Then another important thing which is observed here is Al-Madaris Al-Mustadama program. Now, this program was initiated by the Environment Agency in the Abu Dhabi, and it is a sustainable school initiative which was taken in 2009, and it is still continued. And one important thing is that they take the children out in the community environment. They teach them how to do the plantation. Okay, then field trips are constructed, how to maintain the climate, how to plant the trees. Okay, and they conduct the audit in the school. When they are conducting the audit in the school, they involve students only. Usually what happens when there is any audit and all, only faculty or the staff is involved, but in this program, they involve the students also. So they know how to preserve the energy, what to do with the best material, and how to protect themselves from that. So that is a very good initiative they have taken in this matter, and still it is continued. The eco clubs are there, very good activities they are planning, so that which can promote the heat resilience in the children. Then another important thing is like campaign by police and road transport authority. It was very nice, like it was done for the workers. But when they are also aware, definitely their family members, they can also teach the community, isn't it? So that was this initiative was taken by on 8th of August 2025, Prevention of Heat Exhaustion Campaign, Ministry of Health and Prevention, MOHAP, in collaboration with the Supreme Council of Family Affairs in Sharjah. It was conducted, and they were taught how to protect themselves from the heat in the UAE. Then in relation to the specific Emirate-specific authorities, Emirate EHS, as all of us are aware about it, Emirates Health Services, they provide preventive measures for schools, including heat stress monitoring in government institutions. Dubai Health Authority issues guidelines for educators on recognizing and avoiding the stress in children. Whereas Abu Dhabi Department of Education and Knowledge, they enforce health safety policies with emergency protocol aligned to heat risk. So every emirate has got their own way how they protect, how they guide the community and the people to protect the children from the heat related problem. Not only the children, for other community also. So in conclusion, I think Dr. Rabab, here just I want to say one thing about this heat campaign, which I was in a hot cars awareness campaign, summer without accident, and check the backseat program. See, in UAE, I could not get the data which specifies how many, though they say that in the casualty during the summer season, the chances of heat problems, heat illnesses, children are coming. But there is no statistical data is available. But in US, one of the report which I saw in California, every year approximately 37 to 39 children die because they are left alone in the unattended in the car, and because of that the child has died. So this is a very disastrous thing which we need to think, and it can happen. It must be not intentionally anybody will do, but this is the chance which can happen. So this campaign by the police, and they really educate the people that we should always check when mother is or we are getting down from the car, we must see whether backside, check the back car seat, so that we should be aware. Sometimes children are sleeping, so mother, I don't come, so we are not aware, which can create the problem. Okay, so it's one of the important campaign. It's very useful to protect the children from heat illness related illness. Now I would like to Dr. Rabab to conclude our session.
As you know, UAE is emerging as a leader in the developing innovative and evidence-based strategy to promote the heat resilience and ensure safe outdoor play among children. Prioritizing the heat resilience support healthier, more active children who are better prepared for warming climate. This initiative is essential for long-term community health promotion and sustainable child-centered urban planning. It is very important to foster the health literacy of the school, family, and community about the prevention of heat-related illnesses. Thank you so much.
Thank you. Do we have any questions? And of course, the individual representative can be on stage now. Who will stage with today?
She told in the stage. Okay, now? Yes.
Next, we have Mr. Winter, from Canada. From presentation catalyst, the strategic role of CROs in accelerating clinical trials, a North American model for faster and more efficient research in the GDP. Please welcome Dr. David. Thank you.
Hi, everyone. Yes. Hi, everyone, and thank you for being here. Today, I'll be talking about how can the GCC position itself as a clinical trial hub by 2030 by bridging the North American expertise with the agility, the ambition of our region. And what we are talking about, it's not theoretical, it's a practical and executable roadmap of existing and proven model already. So the clinical trial, je suis pas habituée à ça. Bon. Okay. So the clinical trial research is at a turning point with the increasing of trial complexity and the rising costs of trials and the regulatory pressure, and also the global market requirement for developing a new drug. We have think to adopt a proven North American operational model that we can implement in the GCC to accelerate the research and to accelerate the development of new drug and the access for patients to new therapies. So globally, the current model actual in the GCC is unsustainable, and the average cost for a new drug is $2.6 billion to develop a new drug with a timeline of 10 to 12 years for like the timeline. So if we talk for cost and timeline and regulatory obstacles like blockage, all these things like push us to create a new paradigm shift to a structured efficiency and speed. So why the GCC? Why we choose the GCC as a new hub for 2030? Because of the alignment of the vision in the region of GCC in 2030. And this is also with the heavy government investment in healthcare and in research and development. And also because of the diversity, genetically talking, there's a big diversity in the GCC. And what we call the drug naive population, which is critical for the speed of developing a new drug. Also, the government are fortunately actively modernize the regulatory, they modernizing regulatory. So that's one point also why it could be a good targeted region. But despite all these strengths, there's remaining gaps. So, and there's gaps in timeline between like different sites and sponsor and different actor. So there's a lack of coordination between, for a clinical trial, we have the main three actors, the government, sponsors, and physicians. When I say clinical sites, it's physicians. So we have a real problem in the GCC of coordination between these three actors. We have fragmentation in the process, and also there's a lack in large-scale CROs that are have good knowledge of this region and good expertise of this region. Also, there is a big challenge in the recruitment of patients. In one hand, we have a very good population diversity and high prevalence for some, like in lots of therapeutic area, but we have also like the traditional model of recruitment is not anymore sufficient. Sorry for my English. Okay. Okay. So let's talk about solution. Okay. For the solution, North American model has proven a very good results using standardization, risk-based quality management, the inspection readiness, and also the digital tools. So by implementing standard operation like SOPs, proactive issue detection rather than reactive fixing, we have the latest versions of digital pharma like EDC, CTM. There's lots of others that I didn't mention here, like the ETMF for a trial master file, and for EDC it's for data capture. So all of these tools allow to the American model to go fastly and have the dramatically proven positive results. So if we talk about success in 2030, how it looks like, it's the first thing we targeted harmonized clinical trial ecosystem, une harmonisation. Also to push research center to operate with a global efficiency benchmark, and also a self-sustaining CRO ecosystem that attracts international sponsors. And also to implement the digital and the digital tools and decentralized clinical trials and remote monitoring. So how to achieve this target or these points? There is 5 strategic enablers: the regulatory acceleration, capacity to building, the CRO standardization, and technology adoption. And the main and the most important point is partnership between the 3 actors that I have mentioned: the government, sponsors, and physicians. That's where ClinBridge, I didn't mention in the beginning that it's exhibitor presentation. So now I will talk about the role of ClinBridge and his advantage and where it positions itself. So for the purpose of our CRO, its contract research organization, is to bridge in the North American rigor to GCC operational execution, and also to induce the facility of decision and the site to push and accelerate the site activation and the startup regulatory packages, also to connect these 3 actors. So when we talk about impact, when like we have protocols and structure applied, that we can measure the outcome. The outcome is measurable, okay? So we, in our case, with adopting this, like the points I've mentioned, we achieved 40% faster enrollment rates versus the regional average. And also, we were able to get the regulatory startup packages under 6 months, and also significantly reduced rates of we have live data visibility. And also we have improvement in project timeline, delivering therapies to patients sooner. So what is the key takeaway today? It's when we combine the digital innovation with operational discipline, we will have faster trials and sooner like drug development and sooner access to for patients. And this is the purpose of clinical trial. It's a shorter timeline and access, patient access to the drug development. So we are building a future where the GCC is primary destination for global research and development. I mean, here in GCC, we have the infrastructure. Me, I come from background of 15 years of clinical research in Canada. And I have learned that when we work in cooperation and when we coordinate, nobody can work alone in his space. If we want to advance in the GCC, we should, mainly if we want to attract the international research, the real trial. Here we have post-market studies and we have a lot of regulatory, and sometimes we import medication from outside. But we have a very high scale of physicians and also high qualified PIs and staff in clinical sites, and also the infrastructure. It's impressive, but I all the time ask myself why we don't have encourage the clinical trials in our countries and in these regions. So this is the target of CROs. When we, as like international sponsor, when I work in collaboration with the CRO based in Saudi Arabia or in Emirates or this region, or even in North Africa, we are covering also the Africa region. So the role of CRO, Clean Bridge, it's like a connector between actors. So he gonna outsource these studies to you, and he feels safe that the SOPs and the high standards are applied as per the international requirements. So this is the purpose of our and the mission of our company, and thank you very much.
Thank you very much, Dr. Nim. Tell please, has this clinical trial program funded only government clinic and all the clinic?
Say it again, please.
Government clinic and medical clinic, this program.
But for this program, it's act between government and private, like pharma, like the big pharma. For example, if Pfizer, Sanofi, X Pharma want to conduct the trial in GCC, so when we ensure that this trial is going to be conducted as if it was in America or in Canada, so because they don't have all the time their staff here to submit to regulatory, when we are in the place local, we know all that details. But if there's something that they can do remotely, for example, we found a director in Turkey that cover the Middle East, for example, because there's like post-market or some task that could be done that way. But to conduct a study, you need someone who go to the clinical site to do monitoring, to talk to the PIs, to discuss about the study visit of patients. So when we do that kind of, like we on enlève une charge.
The charges.
Yeah, and this company, yeah, so you connect, you tell the company, I'm here for you to be that contact point between you, between physician and between government. If you need any submission to Health Dubai or Health FDA, or so you work with government and with private companies. Yeah.
Second question.
Yeah.
Can you did you use artificial intelligence data collection information?
Not yet. We use digital platform like EDC, like ETMF, like VivaVolt for ETMF, like platform digital, but not EI yet. We use EI for Play EI. It's platform, like it's program that sometimes help you to have, for example, you have study 1, 2, 3, you're gonna have visibility and where is your recruitment status, where's your are you achieving your goal in timely way, that kind, but not more than that as I approach.
Thank you.
Thank you.
Thank you for the sorry, I missed the remarks again. My first question is medical devices. So medical devices, something as small as our products, that kind of thing. I guess I would just want to know what your experience has been in the context of the fact that if a sponsor comes to you tomorrow with a medical device, she should be pretty fast to get into the kind of realm. Is that something you can deliver? And then we talk about the use of your system is automated, because what's most important for the material of the eye, FDA wants to see it, and they must be able to see it in America. It must be safe with the hands of the way to do it. So can you do low-hanging fruits over-the-counter trial, like a medical device trial, not necessarily with big medications, or something like a combination of this trial? And then my last question is, when you talk to CROs, what they tell you is a fraction of percentage and the cost effective.
Can you repeat it, please?
Are you cost effective? So, for example, I know what operators to how much they take for trials in America. So, if they're doing trial 2 people, is it going to get cost effective? Just people don't talk about the numbers, but you can give me an idea and say, we're going to charge you 30% of what you get. What operator want you to do?
You talk about the similarity between costs, America versus.
Cost number one. Second thing is it's like just inward counters, like just medical devices, not necessarily biologics and stuff.
Yeah. Yeah. Honestly, with that, for medical devices, the project I have now, I don't work yet on medical devices and in the context of ClinBridge, but I did before with a company where I worked in Canada, and it has been implemented in the GCC, and I have been like the project manager of this, and it was a medical device with Bausch & Lomb. And it's something that is included in our package as service. Like what is included exactly in the registration? If for example you want the regulatory aspect, registration of the medical device, and also if there's a trial for this medical device and you target to do this trial in clinical sites in GCC in Dubai or in Saudi Arabia. Yes, we can do the management of the study, like the site feasibility, the startup activities, until the closeout visit. Yeah. And in terms of cost, sorry, yes, for sure, it's taken in consideration the cost in North America versus the GCC region. Yeah. If you're interested, I can give details after. Yeah. Thank you.
Thank you so much. Okay, so we have our next presenter, Dr. Kansel Bekhari from Russia, is postgraduate, intraluminal organ preserving invasive surgery for treatment of supergiant neoplasms of colon by EFP. Please welcome Dr. Bekhari.
This Assalamu alaikum. Hello, dear colleagues and member of the Presidium. I would like to express my gratitude to the conference organization for using us the opportunity to present our clinic experience in treating patients with giant neoplasm of the colon on the international stage. Let me to introduce myself. My name is Gamzat Dakhayev. I'm a resident at Sessional University. In the relevance and problem this situation, endoscopic submucosal dissection is currently the main method for removing large and giant benign epithelial neoplasms and also early malignant neoplasm. Currently, in many countries and regions of our country, patients with large benign neoplasm of the colon still undergo major surgery. These operations are often accompanied by complications, high material costs, and temporary decrease in quality of life. We would like to express our special gratitude to the director of our clinic, Professor Petr Sarkov. Thanks to Petr Sarkov, since 2019, yes, patients with large benign neoplasm of the colon have been undergoing organ preserving, meaning invasive ESD surgery at our clinic. This slide shows the most significant differences between these two types of interventions of patients with benign neoplasm. As for the most common complications after major surgery, we will focus in the following slide. Post-surgical complications. The main complications after surgical interventions are presented in the table. This data is based on global practice, not exclusively on our clinic. Here are some factors that increase the frequency complications after surgical. Factors influencing this percent. First, the type of surgery. Laparoscopic surgery usually has lower complications than open surgery. Patient condition, age, obesity, diabetes, steroids, and poor nutrition. All of this increase the risk. Surgeon and clinic experience. High volume centers consistently show better results. And reason for surgeon. Cancer, diverticulitis, and inflammatory bowel disease. Each carries its own unique risk. It should be noted that the traditional surgery is not a guarantee of a 100% cure, as illustrated in the following slide. This is not the first time that residual tumors have been found in a anastomosis area after surgical resection in the of the rectum. Those tumors that appear to be benign were removed by ESD. The many colleagues surprised by our work in the anastomosis area. This is because the submucosal layer is almost absent, and metal staples are often found. But despite these difficulties, we managed in all cases. So to evaluate our results, we turn to scientific publications. They are no more than 10 of them in world literature. The most recent data are presented by our Japanese colleagues. They are the founders of the ESD method. Also, their patient is significantly larger than ours. However, despite the complexity of learning this method, I would like to say that in many respects we have already matched the results by our Japanese colleagues. The following slide presents a comparison of the results. This slide shows the results achieved by our clinic and by Japanese colleagues. The first thing that catches the eye is the number of operations performed. And of course, the time required for the operation. Our Japanese colleagues perform this operation twice as fast. I would like to note that the number of radical operations performed at our clinic doesn't differ greatly from that in Japan. We do not fully understand why the number of postoperative strictures in our patient differs from that in Japan. The most possible reason for this may be anatomical features. And this slide shows the distribution of ESD procedures performed by a colon section. It demonstrates that in most cases giant neoplasms are found in left section of the colon. Possible complications of ESD. We have discussed the advantage of the ESD method compared to traditional surgery. It is almost important to note the possible negative effects during ESD, which are presented in the table. We consider bleeding that takes more than 2 minutes to stop to be statistically significant. The video shows intraoperative perforation with visualization of a abdominal cavity. It was successfully closed with clips. And grade of fibrosis. The speed and time required to perform ESD also depend on the presence or absence of fibrosis in the submucosal layer. Degree fibrosis, where F0 is good visualization in the submucosal layer, F1 is poor visualization of the submucosal layer, and F2 is a complete absence in the layers in a limited area or throughout the entire submucosal layer. Also, F2 fibrosis, after F2 fibrosis cannot be differentiated from true tumor invasion into the deep layers of the wall. The video shows dissection with an area of absence fibrosis in some of the submucosal layer. Let us move on to the pathomorphological conclusion. In 70–80% of cases, the removed tumors were benign and early malignant. For them, ESD became curative operations. Risk factors were found in 10 patients. 6 of them underwent surgery with extended lymph nodes dissection. No metastases were found in the lymph nodes, and 4 patients continued under dynamic monitoring because of their advanced age. I would like to present a clinical case to you. The patient is 76 years old with a large number of additional pathologies. One of them is a chronic neurodegenerative syndrome or Parkinson's syndrome. During a screening colonoscopy, a benign neoplasm was found in the sigmoid colon. It was almost circular in shape. At another clinic, the patient was offered sigmoid colon resection with a temporary stoma. Given the patient's serious condition, his relatives were looking for an organ-preserving surgery option. We held a concilium and decided to perform a mini-invasive organ-preserving surgery using the ESD method. The surgery lasted about 6 hours and was completed successfully. As we extended stricture is possible at the area of the postoperative defect. The patient received four courses of balloon dilatation of the narrowed area, and we achieved the desired results. In conclusion, the transluminal organ preserving approach allows for the removal of supergiant colonic neoplasm. This is very important in the era of modern medicine. However, success depends on the level of specialists and the technological equipment of the clinic. Our results allow us to conclude that the ESD technique in the treatment of patients with supergiant neoplasm of the colon is highly safe, reliable, and organ preserving. It also improves quality of life. That's all from my side. Thank you for your attention.
Do we have any questions?
Thank you very much, Zat, for your leadership and for your English. Tom, please, what question do you your clinic use to evaluate the neoplasm?
Переведи по размеру.
What classification do you use?
Это прокат. Переведи полностью. Переведи. Классификация эпителиальных образований. Просто вот оцениваем по КУ. Нет, имеется в виду оценка по КУ. Это. Давай я тебе скажу, ты Ну, изначально и оцениваем образование по КУДа, как мы...
First, we assess neoplasm, the food classification.
Поверхностный ямочный рисунок, то есть по...
The surface
Размерная классификация, в этом случае мы, правда, нету определенной классификации, то есть в некоторых публикациях там 4 сантиметра и больше считают там крупными.
Scientific classification to assess tumor like big or small, like
То есть нет определенной классификации по размерному ряду.
Yeah, we don't have classification for tumor cells.
Paris classification.
I noticed you were using the BOEM needle.
What?
The needle. I work in BOEM needle. It is your central policy always to use Boeing needle for ESP. The needle you show needle.
Иглу.
Прикольно. Yes, I would like to know, maybe knife or
Knife?
Нож, да, я тоже.
In colon dissection, we use knife in 1 or 2 millimeters. Yes.
Short needle for ESP, long needle for BOE.
Yes.
I noticed the knife needle is long, like a BOE.
Сейчас. Я понял, про что. Типа вот здесь, ну, переведи ему. Когда мы по фиброзу идем, слой уверенный, то есть в этом случае там берут куш, и то есть 4 миллиметра размер. Наверное, this knife, yeah? 4 millimeters fibrosis. Fibrosis самокодal layer.
Yes, that's what I wanted to know. Why it's long? How I know for fibrosis?
For fibrosis, 4 millimeters knife in long.
Thank you very much. This for this very large volume. You US before
При таких новообразованиях потенциальным риском злокачественности принятия двух
Практически никогда не принимаю. No using. Мы их удаляем с диагностической целью, чтобы стадировать.
Yeah, they like if we see some neoplasm, we have to do all of this and take to pathomorphology for surgery.
So if there is any lesion, then you only.
Если он есть подсоединение.
Идет к хирургам, то есть нам дают фактор риска, если там R1, RX, тогда то есть не определено там, то он идет уже к хирургам. Хирургическая операция после нас.
Я имею в виду, как ты понимаешь, что точно нет поляризации?
А мы уверены, ну, практически никогда. Просто вот с диагностической целью стадировать просто. Наша не...
We not use just diagnosis only because we have like the signs of like potential non-disease, like no like acute pumping or like no plasma or something. But the first, if we see, we just take it off and go to the surgery. Or we go to pathomorphology or diagnostic. And if it's a tumor like we take them to the surgery.
What is absent to the position if through the ESD procedure, if we don't have lifting, this is invasive therapy.
Ну, при не поднимается, да. Okay. Okay.
We have engaged by Dr. Bisma Edwin from UAE for presentation titles and promoting individuals and undergraduate learning students for cross-sectional study. Please welcome Dr. Edwin.
This first. This last. Doesn't make. Very good afternoon. Do you want to keep it? It's okay. Yeah, I will use the pointer. This is a slider. Yes. I will see. I can manage. Very good afternoon. I'm Dr. Vimala, RAC College of Nursing, RAC Medical and Health Sciences University, Ras Al Khaimah. I am very glad to stand here to present my topic. I would like to thank the organizing committee, Dr. Catherine and team, for the opportunity given to me to be the part of this conference. I hope my research topic will be interesting, important, and effective for everyone. The title of the study, Health Promoting Behaviors Among Undergraduate Nursing Students at Selected University in the United Arab Emirates, a cross-sectional study. These are my research contributors. Outline of the presentation, background and need of the study, aim and objectives, research methodology, results and interpretation, discussion, limitation, recommendation and conclusion, references. To begin my presentation, some of the famous quotes given by some of the authors. The groundwork for all happiness is health. The key to a healthy life is having a healthy mind. Exercise is the not only to physical health, but to peace of mind. Moving on to background and need of the study, health promoting behavior is a vital aspect of an individual's growth and development. It represents a continuous process that empowers individuals to enhance their self-control, leading to improved health. It is given by World Health Organization 2025. These health promoting behaviors are self-initiated, fostering a continuous state of well-being. Health promoting behaviors encompasses consuming a balanced diet, engaging in regular physical activity, refraining from disruptive behavior, promptly identifying disease symptoms, maintaining emotional stability, coping with mental distress, spiritual growth, and fostering positive relationship with others. In addition, regular physical activity reduces depression, stress, maintains cardiovascular fitness, psychological health, and healthy life. These health promoting behaviors play a significant role among university students, supporting their future personal and professional roles. University students are going through a transitional period from childhood to adulthood, characterized by physical, psychological, and social development. Promoting healthy behaviors during this period
increase their chances to be healthy adults in the future. Particularly, nursing students, they are future healthcare provider. They are expected to be healthy model that influence their personal well-being and professional practice. Despite the significance of this issue, very few studies were conducted in the UAE. To address this gap, this present study aimed to assess the health promoting behaviors of undergraduate nursing students of selected university, the United Arab Emirates. The specific objectives are to assess the level of health promoting behaviors, to determine the association between selected socio-demographic characteristics and health promoting behaviors, to examine the relationship between different components of health promoting behaviors among undergraduate nursing students. Moving on to materials and methods. Study design, quantitative and cross-sectional descriptive survey. The study was carried out among undergraduate nursing students at selected university UAE. The study population was all the 4 years of undergraduate nursing student. The sampling technique was consecutive sampling technique. Sample size, the total number of students in all the 4 years of BSN program were 357. Since the consecutive sampling was followed, we have invited all the students to participate in the study. However, 255 students participated with a response rate of 71.5%, 3.5% declined to participate, and 25% not responded despite sending repeated reminder emails. Data collection instrument, a self-administered questionnaire were used. It had 2 sections. Section 1, socio-demographic data. Section 2, health promoting lifestyle profile 2. It's a standardized questionnaire developed by Walker. The tool contains 52 items on a 4-point Likert scale. It had 6 components. Health responsibility, it has 9 items. Physical activity, it had 8 items. Nutrition, it had 9 items. Spiritual growth, 9 items. Interpersonal relations, 9 items. And stress management, 8 items. The sum of the HPLP2 score was classified into 4 levels. 52 to 90 considered as poor, 91 to 139 moderate, 140 to 168 good, and 169 to 208 excellent. Validity and reliability. The content validity was performed by the experts. No changes were made in the questionnaire. Cronbach's alpha of 6 components. Health response, the overall, for the individual components, it had good to excellent reliability, but overall 0.953 across 52 items, suggesting excellent reliability. Ethical approval, the study was approved by Rakamatsushi Research and Ethical Committee. Data collection procedure, the data collection was carried out for 2 months from December 2023 to January 2024. Data collection was conducted through an online questionnaire. Initially, the researcher, actually we met the students in the classroom 5 to 10 minutes before the lecture. We explained the purpose of the study and we encouraged the student to participate. The estimated time to complete the questionnaire were 10 to 15 minutes. Maximum of 3 reminders were sent to the participant to complete the survey. Data analysis, SPSS version 29 was used for analyzing the data. Descriptive statistics, high-square test used to determine the association between social demographic characteristics of the participants and health promoting behavior. The Pearson correlation test was used to assess the correlations between different health promoting behaviors components. The statistical significance level for this study was set at the P level less than 0.05. Moving on to results and interpretation. This figure shows the distribution of student socio-demographic characteristics. The more number of participants from the age group between 18 to 20 years, the more number of participants were female, single 93%, with no children 89%. The more number of students from nuclear family, then the more number of participants from year 1 students comparing to other 3 years. The more number of participants from the previous semester GPA between 3.1 to 4, then more number of participants from Ras Al Khaimah. This table represents the mean score of health promoting lifestyle and its subscale. The highest mean score were observed for spiritual growth and interpersonal relations, whereas the lowest score was observed for physical activity and stress management. This figure shows the overall level of health promoting behavior. The majority of the students exhibited moderate health behavior. The significant participants exhibited the good and excellent health behavior. A notable minority were poor health behavior. The table 2 shows the association between socio-demographic characteristics of the participants with health promoting behavior. All the socio-demographic data significantly influence the overall health promoting behavior. Table 4 shows the correlations between different health promoting behavior components. Each sub-components of health promoting behavior substantially contribute to the overall health promoting lifestyle. So there is a very strong positive relationship suggesting that students who take greater responsibility of their health tend to have higher overall health promoting behavior. Moving on to discussion, nursing students are exposed to health promotion concept through their academic curriculum. Actually, they are learning from the first year. However, there may be a gap between their theoretical knowledge and its application in their personal lives. This study investigated the health promoting behaviors of undergraduate nursing students at a selected university in the UAE. The sample predominantly consisted of female students, which is consistent with the nursing professionals' typical gender distribution and with findings from similar studies conducted in the Middle East and other parts of the world. As for the current study, 49% of the participants showed a moderate sense of health responsibility towards health promotion. It's consistent with findings from Jordan, where nursing students similarly practiced health promoting behaviors at a moderate level, which supports the assertion that their theoretical knowledge does not necessarily translate to application in their personal lives. The highest mean squares were observed in the spiritual growth, aligning with other studies conducted in the Middle East. This findings reflects the strong influence of religious values, student beliefs, and daily practices. Interpersonal reactions scored the second highest. This findings aligns with studies from Asia, where interpersonal relations consistently ranked high. This can be attributed to the UAE's strong family bonds and support system playing a significant role. Physical activity and nutrition among nursing students in the Middle East remain a significant challenge, with regular exercise not well integrated into daily routines and often regarded as a low priority leisure activity. This could be due to fast-paced urban environment, limited time, long clinical hours, traveling from other Emirates, spending more time in social media, and it needs to be investigated. A study conducted in other Middle East revealed multiple barriers to physical activity, including volatile climate, cultural constraints, absence of social support, limited time and resources. Stress management, spiritual growth, interpersonal relations, nutrition, and physical activity were all statistically significant and had a positive correlation with health promoting behavior, which is similar to other studies conducted in the Middle East and Asia. The present study noted that students from year 1 maintain moderate health behavior as compared to other 3-year students. This is in opposition to the results in a study conducted by Fasani et al. 2014, where the health promoting behaviors among final year students were significantly better in the other years. Limitations. The study is limited to nursing students. Therefore, it is less likely to be generalized to students from other healthcare professions. Students may over-report because it is a self-reported study, possibly affecting the accuracy of the results. The proportions of gender were unbalanced, which could have affected the findings. Moreover, the study findings cannot be generalized to other emirates of the UAE because it was limited to one university. Conclusion and recommendation. The present study found that overall, the undergraduate students scored higher score in spiritual growth and the lower score in physical activity. Overall, majority of the students have a moderate level of health behavior and a very small number of students have excellent. This study findings highlights the need for more effective strategies such as regular healthcare awareness, seminar and workshop to enhance the health promoting practices. Take home message. As an individual, you need to maintain your health promoting behaviors. As a parent, you need to cultivate health promoting behaviors, especially physical exercise and stress reduction technique among your children. As a healthcare provider, you need to give awareness to the individuals to maintain healthy community in UAE and around the world. To end with some of the famous quotes, our bodies are our gardens, our wills are our gardeners. Today is your day to start fresh, to eat right, to train hard, to live healthy, to be proud. Eating healthy food fills your body with energy and nutrients. Imagine yourself smiling back at you and saying thank you. These are my references. Thank you. Any questions? Thank you.
We have our next presenter, Dr. Gurvi Islam from Russia. His presentation title is POEM, a minimally invasive endoscopic solution for pediatric achalasia, a case report. Please welcome Dr. Islam.
Yep. Can I use it? Yeah, I like to use the video because, you know, it's a long way. I have to be sure.
This one,
And try this one. No, Gregory. Thanks. Thanks, mate.
you can use the clip forward. It is forward.
It's more of this.
Yeah.
Right. Dear colleagues, I can't even describe magnitude of my regret to be in this marvelous city, and I glad to represent Rochelle Children Research and Clinical Center, Moscow region. And we're gonna talk about PAM. It was not our first experience because we opened like maybe half a year ago, and we're gonna show you what the result of our working. Rochelle Clinical Research and Clinical Center is a modern multidisciplinary medical complex that provides high-tech medical care to children from the Moscow region and other parts of Russia. The center is flagship institution in pediatric medicine in Russia. Okay, the Department of Endoscopy diagnostic and treatment at the Rochelle Center, equipped with the latest Olympus equipment, including Havix X1 and a video imaging system, a large fleet of 1,500 series endoscope with HD imaging and with advanced visualization system like NBA, FDI, TXI, and another one. The department operates 3 procedure rooms. We do gastroscopy, colonoscopy right there, and along with recovery rooms, the patient after sedation, you can see it on the right side. And we have really good equipment, all of new, buying one year ago. And let me follow. Okay, what we do. The department, or our department performs virtually the full spectrum of diagnostic and interventional endoscopic procedures. Diagnostic procedures include gastroscopy, colonoscopy, and bronchoscopy, capsule endoscopy as well, and endoscopic ultrasound. Our surgical capabilities, it's polypectomy, endoscopic submucosal resection, endoscopic mucosal resection, and parallel endoscopy myotomy. Emergency endoscopy includes that you can see below, the most of them it's foreign bodies. In the screen there's foreign body of rectum, don't ask me about it. And the below it was like family adenomatous polyposis. It's a disease with really high risk of malignization. That's we decided to do endoscopic submucosal resection. Okay, let's be close to the topic. Achalasia, from Greek, is absence of relaxation, is an esophageal disorder of unknown etiology characterized by inflammation and progressive degeneration of neurons in the Auerbach plexus. The result in irreversible loss of propulsive peristalsis and the distal esophagus, impaired relaxation of the lower esophageal sphincters, and the development of dysphagia. In the adult population, contemporary studies report an annual incidence like 0.74 per 100,000 persons, which is typically presents between the age of 20 and 60 years, affecting both sexually equally. The disease is significantly more rare in children. It's approximately 0 and 11 per 1,000 children annually. And symptoms including progressive dysphagia to liquids and solids, regurgitation or vomiting of undigested food, nightmare cold, aspiration, recurrent expiratory infections, and more typical for children is wet pillow sign, weight loss, gross delay, malnutrition, chest discomfort, and for children again it's hypersalivation and allostosis. Diagnostic method includes clinical examination, radiography, endoscopy, and high resolution manometry. It's approved like a golden standard. Okay, the first one is clinical. For clinic, we use Eckhart score. I think we don't gonna spend a lot of time. It's just to be short, 0 to 12 point scale, assessing achalasia, severity, dysphagia, regurgitation, pain, and weight loss, used to be monitored treatment response and long-term outcomes. Next is radiological method. In Russia, in Eastern Europe, if I'm not mistaken, it's Ukraine, Latvia, and Lithuania, we use Petrovsky scale. Is that we say it's old but gold. But in West, practitioner just use without some assessing numerous degrees, just dilatation of the esophagus and lower and some kind of, I'm gonna show you. They, all of us, like Western colleagues and Russian, more used like common signs of radiological signs of achalasia is dilatation of the esophagus body. On barium swallow or chest X-ray, you often see a markedly widened, dilated esophagus. And I think the second is bird beak, it goes, or red tail. You can see like it's a small, it's a dilated esophagus, and below like this is red tail syndrome, like the liquid can passage through the esophagus. Okay, what about endoscopic examination? Primarily attention is given to the degree of esophageal lumen dilatation and the presence of residual food, fluids or mucus. At the same time, the condition of the esophageal mucosa is assessed, including the thickness, color, sheen, and the presence of absence of peristation, typically finding during esophagogastro. The duodenoscopy include weakened esophageal peristalsis, including inadequate relaxation of the lower esophageal sphincter. The next one is a golden standard, high resolution endoscopic manometry. Chicago classification is a globally accepted standard. It was first introduced in 2008 and subsequently received in 2011 and 24, and the last version it was 2024. In Chicago classification, we have three types of achalasia. First one, it's a peristalsis. The esophageal body shows abscess of contractility. No significant preservation is observed. Type 2, it's a pan-esophageal pressurization, while peristalsis is absent. There are simultaneous isobaric pressure increasing. And type 3, it's more curable for a poem. It's a premature spastic contractions. At least 20% of swallow trigger raped premature contractions. And the last one, or not the last one, next one is treatment. What about pharmacological therapy? It's used nitrates and calcium channel blockers. Their role is temporary symptoms relief used in patients until for procedure, but it's not effective for all of types of achalasia. To be honest, it's just for help the golden standard method like POEM or helermiotomy. And the next one is botulinum toxin injection. It's like effectiveness around 80%. But it's also not used because it's not gonna relieve the symptoms in long term. Pneumatic balloon dilatation, we also don't do this because after that we're gonna have a scarring and we can do some POEM. We will have a risk of perforation and a lot of complications. Surgical helermiotomy with fundoplication. It's also called gold standard, especially for, I said to you about three types of achalasia, but we have the first one. It's S-shaped deformation of esophagus. We can't use their POEM. That in this case, we're gonna use classical helermiotomy. And I think we have to go to helermiotomy more precisely. It's surgical division of the lower esophageal sphincter and proximal gastric musculature to relieve obstruction in achalasia, routinely combined with an anti-reflex fundoplication, which called Nissen, we know. And I'm not going to tell you about standard laparoscopic technique. You can see it's not many important and main complications like intraoperative is mucosal perforation, 5-10%, it's not so much. Early postoperative is bleeding, infection, and pneumothorax as well. And next one is POEM. The POEM, it's accepted as a golden standard in many countries because it's a mini invasion endoscopy procedure, is organ serving operation and creating a myotomy of the less and esophageal muscles via submucosal tunnel. Like technique, mucosal injection we need, and creating submucosal tunnel, we endoscopic division of circular muscles layer along the tunnel, and we close it using clips. All right, let me see. Okay, this is more important question. We always arguing with our surgeons about which is better, and surgeon from old schools, they really like to do a hilar myotomy. Doesn't matter it's helpful or not. They want to do it just for maybe making money, or they just too old to, be open-minded. Then every case they use hilar myotomy, but if we can do mini invasive operation, it's better because we have to think about patient's life first, not do some competition against each other or making money. We have to make patient's life better. You can use effectiveness. All of Punkts is like POEM. It's much more better than myotomy, except maybe esophagitis, but esophagitis is not a big problem. That we have a lot of drugs to cure it. That I think it's POEM is winning here. Okay, let's talk about clinical case. 11 years old patient came to our department for just checking upper endoscopy, do a progressive complaints of dysphagia, solids and liquid, regurgitation. Since the onset of symptoms, she had experienced a significant initial weight loss. She weight loss around 8 and 9%. And we can see her endoscopy as well. As you can see following the procedure, the contrast, we can see like dilatation of the esophagus, and we can see also we can see liquid. Liquid is always in the esophagus, and in the distal part of the esophagus, we're gonna see like esophageal sphincter that get be tight and difficult to passage through the endoscope. And we also can see X-ray. It's classic symptom. It's of esophagia is blurred, and we can see dilatation. Maybe somebody can help me with video, or maybe I will do it myself. All right, I'm gonna do it. This is like I made the video. It's quite long that I'm gonna do maybe it a little bit faster. Okay, you can see creating submucosal tunnel. We did it successfully. It's quite big. And after that, we starting to cut the muscles. And when we cut the muscles, sorry for that, I should do it better. When we cut the muscles, you can see it's easily come to the stomach. And after that, we're using clips, and that's all. And the results, it was like X-ray after the procedure. You can see there is before painting, and this is a video of after. You can see like the passage is good, liquid in the stomach. And conclusion. Peritoneal endoscopic myotomy has emerged as a leading minimal invasive organ preserving intervention for esophageal achalasia, delivering high technical success and sustained symptomatic improved across manometric types 1 to 3 by avoiding external scars and operating entirely within the endoluminal plane. POEM substantially reduce procedural trauma, shortness hospitality stay, and many adventures like that. And the final, it's artificial intelligence can see me against achalasia. I think it was before, and after that, I'm getting kind of fat, but I think it's better to be fat and happy than shaped and unhappy. All right, thank you so much.
Yes, unfortunately.
I think unfortunately.
Thank you very much for your case.
Thank you, Professor.
I have two questions. First, what anesthesia you use to the procedure for child? So necessary.
You mean general anesthesia, yeah? Yeah, we use, it's always anesthesiologist decided, but they use like mixed combination, like mask anesthesia, and the same time it's blood vein anesthesia. I'm not sure. I'm not watching at anesthesiologist all the time, but I think yes.
Your second question. What is it about high resolution manometry after doing procedure for child? But I know what to think about this question, Sensei. I have my opinion for this procedure. What do you think about this control? This is necessary, maybe no need high resolution manometry after when. What do you think about?
I think it's better to do manometry. In many articles, especially the Japanese, they said, yeah, you can do manometry, but in real life, if they have no complaining, like regurgitation or something, and we can control gastroscopy that everything is good, I think maybe it's not important. And in our reality, you know, like manometry, it's kind of difficult to do. Not every hospital make manometry.
Thank you.
Oh, no, thank you. But I hate Thank you.
So we have come to our last presentation for the day. May I please invite Dr. Kirti Holkar from UK, presenting his title, Career Destiny for Medical Professionals, Award Burnout and Time Fulfillment in the Role, Visualization of its Endothelial Surface Receptors. Please welcome Dr. Kirti.
Thank you. Oops. To begin with, thank you very much, Dr. Catherine and team, for giving me this opportunity to present at this conference. Greetings. Career Destiny Blueprint. Why am I talking about this at a medical or a surgical conference? It's a very valid and important question, I feel. And if you were to look around, there is an epidemic of professional burnout that is happening. And this is in the region of about 40 to 50 to 60% based upon various different publications that you look at. It's common knowledge now that in the region of about 20 to 30% of doctors are being burnt out. And from surgery into getting into this side gig, if you call it, I've helped people, potentially colleagues in the medical profession, prevent burnout And that gave rise to my first book, which was this is at the bottom, which is called Prevent Burnout and Find Fulfillment. This book taught me several things, and it is a succinct synopsis of in the region of about 300 people that I've kind of coached. The common finding was these people had not chosen their careers nicely. They had not chosen the careers scientifically. And essentially, the choice of making the career was haphazard, and that was one of the reasons why they found themselves in a profession they didn't want to belong to. I mean, we've got healthcare is a noble profession, which we should be very pleased and happy that it is that we are in it. Talent is not an issue; it is the choice issue, and that is where my journey from surgery to strategy, and that's called career strategy, that I have moved into. My mission is to highlight burnout as a topic. I've listened to the talk between mindfulness and exercise just 2 talks ago, so it is quite timely. The people who are in this particular situation are not at fault. It is the circumstances that they were in at the time of making the choice that kind of caused the problem. So why does it matter? Well, the wrong choice now can cause up to about 40 years of issues, 30 years of your career, and this syndrome doesn't really finish off at the end of the career. It goes into retirement. So it's about a 40-year issue. And I have had my fair share in witnessing these people. These are, if you look at the statistic in the US, one medical professional a day is taking his or her life, suicide, death because of career burnout. And it's absolutely a staggering figure. And these are publications out in the wild wherein medical professions or professionals are losing their lives. And is there something that can be done? Absolutely, there can be. So the journey is to help either a new student who's trying to choose medicine or somebody who is in medicine. It could be in the mid-career level. We could have a colleague, we could have a friend, or potentially a trainee who is needing this type of help. And I think if you were to be equipped with this information, I think we would be able to do them a huge amount of favor, if you like. So as I said, usually, I mean, we all were between 15 and 25 when we were making our career choices. If at that particular stage the scientific approach was available, it'll be fairly. I don't know why the slides are going forward without me clicking them, but I'll let's come back. So the problem isn't why they choose. The problem is because of some myths that we have, and the myths are the first one being listen to our parents to make a career choice. And as parents, we do the best. I've got 2 kids, and they were choosing at that particular stage, and all I needed to do was look at what scientific message is available, because as parents we want to try to do the best, but again it doesn't come up with a skill of making our kids the best of professionals that can be fulfilled with. So to listen to our parents to choose our careers is probably a myth. It's not right. Majority of them will get it right, but not all of them. That's basically what my experience with the career burnout book was, that 96% of these people who were burnt out had chosen the careers wrongly, and majority, I can't tell you how many at this point in time, but majority of them had chosen because, oh yeah, my dad asked me to do it. Oh yeah, my mom asked me to do it. Oh, my uncle was doing it, and hence I did it. So just beware of it is what I would say. The second myth is follow your passion. Yeah, just if you like watching a YouTube video on marketing, become a marketeer. Or if you like a video of a day in the life of the spinal surgeon, become a spinal surgeon. This is way away from the truth. So just passion to choose profession is not right. The third myth is choose something, and if you don't like it, you can change it. It's not costly. No, it is. It is very costly. It is expensive. It's your fees. It's the time, it's the frustration, it's the lack of confidence after you change from a career to the other one, which would be a problem. The fourth myth is the career ladder trap. So get into something, and as a junior, if you don't like it, well, as you go up the ladder, you will be very happy. My presentation was 20 minutes, but by the way the slides are going forward, it'll finish in 5 minutes. So apologies for that. So the fifth myth is information overload. Now, just take an example. You're just basically going out shopping for a shampoo or a deodorant. And if you have one choice, you just go there, grab it and come home. You have 25 on the shelf, you're going to be confused. So if there are choices available, and at this point in time, there are loads of choices available, and if they were, it is going to be very, very difficult. Yeah.
Video mode, I think. It's in video mode, so it's going.
How do I change that?
It cannot be.
So I have to just, okay, no problems. So it'll, okay. Yeah, so if there are more choices available, it is going to be difficult. But in today's day and age, in 2025, I mean, there are about 600 different professions available. So if you have a choice of 600, of course you're going to be in a bit of confused status. So the reflection is, what are we tolerating? What are we able to do? What should we scientifically look at? And the truth is fairly easy to dig out. And you could be either this young student who's just basically holding her head in her hand saying, I don't know what I have to do. Or perhaps the mother who's basically a mid-career professional who's not happy in the profession that she finds herself. And both of them can be helped. It's all scientifically proven now. And what we need to do is to uncover what the problems are of both the group personnel, either it is the young professional or the mid-career professional. And that's where the second book, which was from my experience of treating the burnt out people, which is called The Career Destiny Blueprint. And if the people who were getting burnt out were not happy because they chose a wrong profession, why spend time in trying to treat people who are burnt out? Why not get them to choose right is basically the work on the Career Destiny Blueprint. And that book is available on Amazon. So step one, so this book gives a very clear 5-step framework. The first one is to clarify, which is identify either the young professional or the mid-career professional with regards to where they are in their journey. The second step is based on learning who we are. And this is a personality psychometric type of testing, wherein you look at various different aspects like MBTI, sorted, isn't it? Yeah. Okay, right. So you look at various different aspects of your own personality, and this will give a bespoke personal strategy to identify what is good for you, not for your parent, not for your mother, not for your friend, but it is for you yourself. And about 90% of clarity comes about by assessing your own kind of personality. The third step, after identifying where your background and your personality, is to architect your career. So you put the findings of your first and second step together and try to identify what is right for you. And at the end of this, these two steps, you get clear about 3 choices available, and then you're able to pick the 1 from 3. So 1 from 600 is very difficult, 1 from 3 is not. The fourth step is to implement whatever you've chosen, one career. So you have to choose 1 out of the 3, and it is very much possible to achieve all of that in about 6 weeks, believe it or not. So once you get that, you implement all your strategies that are found out. And then the fifth step is to stay motivated. What motivates us in the first year of a career is very different to what could be in our 5th year as compared to 10th year and maybe the 25th year. So it is extremely important to identify what they are and how we can do it. So, so how can we achieve it? It can be achieved for $5. That's basically what is the cost of the book I have available on Amazon. Why $5? Because Amazon doesn't let me sell it for any cheaper. The second methodology is an online course, and I've just crafted a course wherein the people, either they are young students or mid-career professionals, can just basically go on and do an online course, and it literally gives you exactly how you go through those 5 steps and identify it. There is a group coaching as well as a one-on-one coaching type of approach available. My 2 kids are product of this particular strategy. My eldest son is working in this very town as a real estate professional, and he's 25 and he's absolutely thrilled. He's working here for the past about 3 years, and he's roaming around the world. So he's in the UK, he's in Dubai, he's in India, he's in Philippines, and he's just loving it. Why does he love it? Because that's exactly what is best for him. If work is play, it never becomes unhappy. And that's basically what he's proven. The second child of mine is a doctor. She is doing her GP rotation, and both of them are kind of fulfilled at this point in time at a young age. She's 24. So if you want to know more about it, yeah, let me know and I'll be very happy to help. Thank you very much. Happy to take questions if there were any. Yes.
So at least for people who are at the beginning of their career or in the middle or the end, at what point do you say that, no, I can't have a career change anymore?
Very good. Very good question. My youngest coachee, shall I say, 66 years of age. When he came along to me, literally, I didn't say, hang on, how can I help you? I said, what makes you come to me? And he asked me a question, and that became a truth. In fact, I've quoted in my book. He said, do you know, he said, Kirti, do you know the richest place on the top of this earth? And I kind of took a few guesses and I was wrong. And he said, the graveyard. Why? Because unfulfilled dreams are buried in there. And he said, it is now that I've realized that what I have been living is not my dream, it's somebody else's. So this is the time that I want to, and he had tried changing things for about 10 odd years. So though he was 66, he was 56 when he was trying to do that. So you know what, age is no bar. The reason is, all I'm looking for is if a person is coachable, if they are able to listen to and take instructions, yeah, it should not be a problem. And it's, I mean, I've helped some lawyers, so it doesn't have to be only in the medical profession, because we're all human beings and we all have a brain. Again, I liked one of the things, the body is your garden, whereas your mind is your own belonging. And it is so phenomenally nice, William Shakespeare's kind of quotation. So to answer your question, yeah, age is no bar.
Very much for your book. Actually, my question is for the younger generation, very young people, age 18, 19. Well, they're still not yet exposed to life and they don't know what school to go back for them. They come to you as a dad and they want to know what advice you will give them.
Yeah. So I'll give you my personal example. My son, who is now a real estate professional, came to me and he said, I want to be a doctor. I was thrilled. I was my younger myself. This is what, about 10, 12 years ago. I said, if you want to be a doctor, fine. I knew he was not the right personality. I said, fine, absolutely, do it. So what I pushed him to do was to make a mistake, but within a few months. Because as a young person, you know, this is my personal opinion, you may disagree. I feel the young kids, and particularly the Generation Zs, you know, these guys are very different creatures, really. I'm calling them creatures. Sorry if there are some sitting here, because my 2 kids are creatures for me. So what I feel is that let them make the mistake and let them learn that it is their mistake, and they will be very, very happy. So I let my son do the mistake of, he wanted to be a doctor. I said, fine, come down to my clinic, just work there for a few weeks. Within 2 weeks, Within 2 weeks, he said that's not right for him. And he came back and he said, Dad, do you want me to be a doctor? I said, look, I didn't ask you to be a doctor. So I said, what do you want to be? He said, he doesn't know. That's when the Career Destiny Blueprint came along. So I took him into, I gave him 3 6-week courses. And those courses were assessing his personality. So there were the 3 choices that he had. So out of that, he said, I like real estate. So we got him a 6-month course. He took a gap year. So gap year for backpacking and kind of going around is one way of looking at it. Whereas the other one is to do something that would be very good for that kind of generation. So he did that for 6 months. He liked it. That's when he started his university degree. So he did that for about 3.5 years. He did not have the certificate in his hand, and he had a job in Dubai with the #1 real estate company. And when he basically got that particular job, he said, I don't know why they gave me the job because I have very little experience. It's not the degree that gets you the job. It's your confidence, it's your personality, it's the way in which you kind of do that. So sorry for a long-winded answer. I feel you need to push them. Don't send them to me. Just get them assessed and do it.
What's your point? Usually those youngsters might have 2 or 3 children, and you know what is this child is and what that is, and what is their preference. Some of them have got very fair academic achievement, some of them just want to work hard. So as that, I think knowing your children and what their preference from childhood, maybe you would be able to advise them the right path.
You know what? I think a large population may be able to do it. I don't think it is 100%. And I'll give you another example. There is a acquaintance of mine. He's a accomplished doctor. Wanted all his children to be doctors, all his children, because all his previous family, he had 5 siblings, all of them were doctors. So he said, I want all of them to be doctors. The first guy, he was in medicine for 2 years, didn't like it, complained every day, nothing happened. He dropped from the university. He eloped from his house, not to be found for 6 months. The dad, who thought that he knows what is, he said, okay, you're not settling here. I'll send you to a different part of the world doing medicine. The son is not to be found 6 years on. So again, it's a vastly extreme example. I feel, we should be able to do it, but if there was, one of the questions was, when do you pivot? If we were to help our children to make a choice, and if they do make a choice, and if they find themselves stuck, I have a formula called 1, 3, 5, 10, and 20. At the end of the first year, if you're happy, fantastic, carry on, do it. 3 years, reassess. 5 years, reassess. 10 years, reassess. 20 years, reassess. Reassess. Don't carry on in an unhappy marriage. That's what I would say. So as dads, as parents, if we were to push our kids into making a choice, it may not be a good choice. If it is not a good choice, pivot. That's basically what I would say. Oh, I won't fall. Thank you.
How long does it usually take? So the program, is it a lifetime? So when you get into the patient, do you assess the person and decide that for this person is going to be lifetime, for this person is going to be a one-time subscription, if I can call it that?
Yeah.
Well,
Again, a very good question. So this can be achieved. If somebody was to read the book, it depends on how long they're going to take to read the book. If they were to take an online course, I say 6 weeks, it's going to switch off, because if you can't get it in 6 weeks' time, you're never going to get it. Group, same thing, one-on-one coaching, 2 weeks. Because look, you get somebody to make a choice of buying a perfume, and there are 25 bottles. You go in knowing what you want to buy. You give them 2 hours and say the shop is shutting, and you're never going to, buy the scent. They will pick up one and come up. Now that is a rushed decision. So what I say is, if the first and the second choice is, it takes about 10 minutes for a questionnaire, and the personality one takes about 25, 30 minutes. So at the end of it, I know what the person is good at, but I can't, it's not my life, it's their life. So I give, and this is a scientifically proven 3 choices. Usually you get about 10 choices. Again, there's no point in giving 10 choices because they come with parameters. So it's a 99% fit and a 96% fit and a 90% fit and so on and so forth. So if they can't take a choice for the first 3, then it becomes confusing. So I give them a choice of 3, and quite a few times they say this is the one for me and carry on. But if they were confused between 1 and 3, 1 and 2, then we can further dissect, and that's the 3rd stage of implementation, wherein I go deeper into. I don't need to know much about that career, but with recent AI, you can literally dig into that profession and literally get them a month in that profession, and they will come out and say, "Hang on, this is not what I want." That was not available. It is available now, and it is all scientific. It's not my theory. It's all of this has been out there for tens of years. I think what I've done is I've just assimilated it. And my 2 kids, and that are very happy, when they came out, I thought, what, but this could be flu. 2 kids is nothing. So I've done that on probably in the region of about 300 young professionals, and they're very, very happy. So I kind of carry on doing it. Thank you. Thank you very much for listening. You have to do it?
Yes. So,
Thank you for the patient listening. So now I request everyone to please come forward to receive your certificate. If you can just come to the desk to give your name, we'll be